Yeah, we've got started on the recording, so yeah.
Good evening, everyone, and welcome to the Adults Health Scrutiny panel. Just like to welcome you all, those online, and we'll introduce you as we go around the room today. My name is Councillor Connor, and I chair the Adults and Health Scrutiny Committee here. We're just going to go around and introduce the councillors, and then we'll introduce cabinet members and officers when we come to particular agenda items that are relevant. So, that's in Hot.
Hello, Tyann Curran, councillor for Woodside.
Penny Brennan, councillor for Muswell Hill.
Helena Carnia, co-optee.
Mary Mason, councillor for Bounds Green.
Alicia Poku, councillor for Tottenham Central Ward.
Councillor Gina Big, South Tottenham.
I'm Councillor Sean O'Donovan, councillor for Tottenham Hale.
Excellent. So thank you. And just to note, this meeting is being filmed and recorded. So by coming into the meeting today, you're agreeing to be filmed and recorded, and this will be put out on the council's website for people to view. Number two, apologies for absence, Dominic.
Apologies to we've got everybody here today.
Any items of urgent business?
No, none received.
Any declarations of interest? Say, member of the RCN.
I've already just, I'm a co-chair of Joint Partnership Board, but that's going to be forever until they chuck me off.
I'm a radiologist, Royal College of Radiologists, and I'm a deputy medical director hospital.
Great, thank you. Any dictations?
No.
So the minutes. So pages 1 to 18. I think you might have been shocked as I was when I turned to these. It's the 22nd of February, and I was just about to get hold of Dominic and say, Dominic, what's going on? Where's the latest? But it is that long ago since we last
It's an election, that's what.
Indeed. So, so just to let you know, if you can cast your minds back to the minutes that we had, I've got a couple of questions on the actions. So, Dominic Spade kindly produced a tracker for us. Dominic, is there anything on the tracker that we've just received that relates to the minutes?
Yes, so sorry, this is a little bit late. We have got, I will circulate this by email along with the attachment, but I think that the most substantive update there is on AIDS adaptations number 38. So we've got quite a detailed response on that. There are a couple of substantive items we should have updates on shortly. I understand they've been completed, just awaiting sign off. So there will be a couple of if anybody doesn't have a copy of the tracker, I've got some spare ones here, by the way.
Over here.
So I just wanted to ask a question on the action. Sorry, apologies. So we'll read the minutes. And so are the minutes. Yeah. So just before that, there was a deputation, and I'm just checking that the action from that. So at the end of that deputation on Osborne Grove, we had we concluded with the code saying the panel would welcome feedback from the cabinet member and officers on the agreed future relationship with that co-production group Osborne Grove. So the structure is clear going forward, and with details on the financial position should be provided. Can I ask if the meeting has happened with that group since February?
I think one meeting has taken place, but they are awaiting putting another meeting in. The subject matter has been discussed at the co-production board where some members sit, but I'll chase and give you an update within a week.
Brilliant. Because I was just hearing anecdotally, and it's always these things that you hear anecdotally that they weren't quite sure what was happening. So I said tonight I would ask if that action had happened. So we're going to get an update. Brilliant. And where does that go to? Did you say which board does that?
So under the commissioning, social care commissioning team, there is a co-production commissioning board, and it's co-chaired by a resident as well, and the information and sign off happens there.
Brilliant. So that'll be an action on their agenda. Excellent. Okay, it's good to note where things are going to.
Chair, could you just add to that the number 35, which was about financial, the financial analysis was to be shared.
Yes. Okay, thank you. Right, okay, so moving on, so we're going to change the agenda item around this evening. So we're going to take the continued healthcare item first, because we have someone coming from the Whittington Health, Anthony, who's coming to speak to us. So we always take external speakers first, if we possibly can. So that's a move around in your agenda. So we are now on pages 19, agenda item 7. No, we're not. We're on the supplementary. Apologies for that. We're on the supplementary agenda item, continuing healthcare. So Anthony, would you like to?
It's got it up there.
Hi, good
Sorry.
evening, everyone.
We can hear you.
Sorry, I put the slides up on the screen and it's cut off the video from you. So I think the councillors do have the slides printed off.
Yes.
I thought, should we stop sharing so we can actually
Yes.
see directly? Yeah.
Yes.
So the councillors will have the slides. I think there's 4, isn't there? So I've got one more spare copy if anybody doesn't have one. I think everyone's got one, so we can. Yeah.
So good evening, everyone. My name is Anthony Rafferty. I'm the Director of Operations for Adult Community Services. I'm here to speak on behalf of Continuing Healthcare, one of the teams based at Whittington. Just giving a brief overview on the first page, what is Continuing Healthcare? CHC means a package of ongoing care that is arranged and funded solely by the NHS, where the individual has been assessed and found to have a primary health need as set out in the national framework. This care is provided to anybody for us, individual over 18 and over, to meet their health and associated social care needs, which have arisen from disability, accident, or illness. And in the next column, we've just got what the aim of the team is, what they want to achieve, and it's to work alongside our MDT colleagues, make sure checklists are completed for all patients who are entitled to CHC, and work alongside our hospital teams, which we are part of here, and the MDT, who are our local authority and social workers. But most importantly, to help identify rapidly deteriorating patients who are end of life, so they're fast tracked automatically and make them eligible for CHC. On the policy and processes, I think it's helpful to know what some of the terms are going to be used are. So we work from a national framework of for NHS continuing healthcare and NHS funded nursing care. Some terms generally used is NHS continuing healthcare checklists, decision supporting tools for continuing healthcare, and fast tracking. I just put the common acronyms there because we all love acronyms in the NHS and local authority. So DST is decision supporting tool, FNC funded nursing care, ICB is integrated care board, and MDT is multidisciplinary team. The checklist is a screening tool which it's used in a variety of settings, whether it be at home or in hospital, to identify practitioners, to help identify those who need a referral to CHC. The checklist scoring threshold is set intentionally low. It aims to screen people in rather than out, to help determine if a full assessment is required. This can be taken from patient notes, from referral information, and general information gathering from families as well. Generally, for a bit more detail, it's scored across 11 domains, and very basically A, B, or C, where 2 A's or more will automatically include you, 5 B's will include you, 1A, 4 B's, or 1A in any areas of behaviour, breathing, or symptom control, and altered states of consciousness. It's a very low scoring threshold. Once that ALH score is positive or negative, if positive, it goes for full assessment of eligibility and they complete a DST, the decision supporting tool. Again, readdressing the 11 domains. There are 12 domains there for other care needs, but on the main 11, they determine how low, medium, or high they are for the individual in that domain. And it determines whether or not what level of care they need in terms of support they need. It also helped determine whether the person has a primary health need using the decision important tool, and whether or not they are eligible for full eligibility. And then we have a fast track tool, as I already discussed. It's for a rapidly deteriorating condition, which may be in the terminal phase. It's a means for ensuring that the person's care is not delayed unnecessarily, so they don't need to go through any checks. Once we have that confirmation, it's automatically awarded to them and support them either at home or in another appropriate setting. If the person is eligible, once we've completed all of our checks and our assessment, we would send our forms to local authority for the social workers to go over. They meet weekly to determine any areas that need clarification, and once complete, it's sent to the ICB for ratification as to whether or not it meets the eligibility criteria of the national framework. I think it's important to note here that Whittington Health as a provider don't determine funding, but rather we carry out assessments on behalf of the patients, and the ICB determine the funding criteria. Once eligibility is confirmed and provided for, a review for a patient will happen at 3 months, and then again at 12 months. And this is just to ascertain if needs have changed. Sometimes at 3 months, people have improved and they may or may not need ongoing support. If it has deteriorated, then extra steps can be put in place to support them. And then again at 12 months again to assess the person's need. That's a brief overview. I didn't want to give you lots of information because I suspect you may have some questions you might want to ask me.
Yes, we do. Thank you, Anthony, for that. And we've also got the information a bit further on, which gives a little bit more detail around all the areas that you've just gone through briefly with us now. So I'm going to start off the questioning and then go around all my colleagues, because you're right, there are lots of questions. So when I first started as a counsellor, this was one area that I first came across. And I realised how difficult it was for that person to try and get continuing healthcare funding. I did actually sit processes with them, and they found it extremely difficult. My understanding is that the figures, not just in Haringey, but across London, are quite low for the number of people that are currently receiving the continuing healthcare funding. Is that something you'd agree with? And if so, is there something in place in order to ensure that not only Haringey, but London comes up to more the national average? Thank you.
Yes, this is something we're aware of locally across NCL. It is lower numbers. It's a area for improvement, and we're working with the ICB to look at ways how we can improve this, and it also involves working with our local authority as well to make sure we've got the right patients per capita.
So how when you say how we can improve this, what actual work is happening and who's taking responsibility for that? And at what point are you going to be able to report, or is anyone going to be able to report back and say, this is the new cunning plan and this is how we're going to ensure that we're going through this eligibility assessment in a level that maybe would be happening in other parts of the country?
Yeah, I think for Whittington Health, most of our referrals come from our hospitals, our local hospitals, and it's raising awareness for our clinicians who are on the wards. We know we've got a high turnover of staff in London, and with maybe more junior staff coming in at all grades and all professions, it's raising awareness and showing them what CHC is. We have recently put, the ICB have recently put in-reach nurses as of this year to each hospital, and so it helps identify those who on our long length of stay meetings and for those who may have increasing care needs is asking our in-region nurses to assess them whether or not they meet the criteria for CHC. And generally those are our patients who would be, we call pathway 3, who are discharged to care homes or similar, and assessing them whether or not what is the nursing need here. Is it a primary healthcare need? Is it CHC? It's a new thing just put in place since I think April this year, and we're looking at hopefully some more data coming through on that. We're also looking at some of our people who could go home with CHC. I think there's a real lack of attention to that in our hospitals, and more work. We're doing more upskilling, more awareness of what CHC is. The ICB have got a bit of work as well on this across NCL.
Okay, and do you know what that work is the ICB have been doing on that?
I don't. I've only started meeting with them recently to go through this with them.
Lovely. If you could let us know after the meeting as a written answer, that would be, if you could ask your colleagues, that'd be great. Thank you. I'm just obviously going to go around the rest of my members here for questions, because I don't want to hold the entire process. So I'm going to look to my left and right and hands up. So I've got Councillor Mason, and then Helena, and then Councillor Brennan.
Yeah. Thanks very much, and thank you for your introduction. Obviously, I can see that there are quite difficult decisions to be made, but I'm a councillor for the Bounds Green ward, and there are people I know who have got continued healthcare and people who have not got continued healthcare. And because Bounds Green ward is kind of divided into a more affluent area and a less affluent area, some of the decisions that are made by authorities are quite stark. And I want to know, I'd like to know about those people who maybe don't have the knowledge of the system or the language and are of a different social economic status, and therefore have less of an opportunity to work within the system to push for continued healthcare. And whether you've got statistics to show the relationship between those who haven't been accepted continued healthcare and their status, language, etc. So whether you collect those stats, and if you do, what they show.
Yeah. So as I said before, this is based on national framework. And for those who don't meet the criteria, there is a process of appeal, and the appeal will normally stay locally first of all to see if there's something we can clarify with the person or the family. If that's not resolved, then it can be referred to the ICB for their involvement. That will involve a senior social worker and a senior assessor from the ICB. And again, if they still don't agree with the outcome, it can go as far as NHS England. So in terms of eligibility, the team stick to a national framework, but I do hear comments on those who are more affluent can probably navigate the system better. With language, they probably they are likely to have the right kind of phrases or come across better. I don't have those figures currently for health inequalities or ethnicity ratio. It's something I can get. It's something where, as a division for adult community service, we're working on for a whole division. But I can work with the ICB and see if that's something we can pull out based on ethnicity and first language as well for those who have been declined.
Thank you. And just to jump in very quickly, is that we know the more complex systems are, the number of appeals, etc., then that's the people who have got greater access to information are more able to work that system. And we know that health inequalities spin out of that. So I think it's really important that we know that the system is working fairly for everybody. So if we can have that data, that'd be great.
Thank you. Helena, I think.
Hello, Anthony.
Hello.
I'm going to find this one quite difficult because my mother got continuing healthcare for a whole 3 days before she died. That was really helpful. But putting that to one side, I mean, I've been working with the health service for many years, and I've never understood why continuing healthcare is denied to so many people that have health conditions. And it is beyond me why it is not explained to those people that suddenly their health condition is no longer a health condition and is suddenly a social care condition. There is something wrong in that system. So I would like to ask you, and this is on a personal level, what do you think has to change, and how do patients and their families and carers and friends, how can they get to appeal to you? Because it seems to be so, I'm not blaming you at the Whittington, but the IC seems to be so remote from reality. So I'm asking you, what needs to change? How can it change? And maybe I shouldn't be asking you, but my God, I've been through this too many times. And I would like to know, from your professional point of view, where does it need to change?
I think CHC is something which will impact us all at some time in our life, and it is very emotive. And I do understand your comments you've made. This is nationally funded money, and it's been determined by government what is continuing healthcare, and they strictly adhere to the national framework, which, when you're so far removed from it, it's hard to bear. It's a wicked problem in terms of funding, and it basically comes down to funding and that the lack of. I think that's very well known, and it's an underfunded resource. The funding itself for Haringey, I think was 13 million for last year. I don't hold the figures for that, but I do think it was around 13 million in total last year, or approximately around that. And so that's for one area in Haringey. And this, unfortunately, what it comes down to at the end of the day is people have to meet the criteria for eligibility to be able to get the funding. And when you talk about somebody who did have CHC and then was thought not to, again, that sometimes people do improve and live with a condition. Again, it's not something I wholly agree with, but we have to stick to the recommendations of the national framework and for it to be ratified by the ICB.
A very political answer. Thank you.
Okay, I'm just going to quickly jump in there because I think I just would like to get some real clarity on this. So other parts of the country, people are getting more funding and are being assessed as eligible. And in London and Haringey, part of London, those numbers are very low. So I can't imagine that we have suddenly got very different cohorts to maybe Blackpool. So why are the figures in other parts of the country much higher for people who can access this eligibility? Are they going through a different screening process? You said it's a national framework. So either the assessors are making a different decision based on exactly the same criteria, or something else is different, and I can't quite work out what.
I would have to refer to the ICB for that particular question. Unfortunately, I can't answer that. Whether or not we are excluding anybody based on funding, I'm of the belief it shouldn't be. We don't hold the funding. We don't make decisions on funding. The CHC team based at Whittington make decisions based on the person's need.
Okay, thank you for that, and it'd be great to have that as an answer back to the committee. Thank you. I've got Councillor Brennan and then Councillor Donovan.
So when I read the continuing healthcare document originally, it appeared to me sort of a bit vague on its because it was telling us that people are assessed, but it was terribly vague, sort of, we're assessed by experts and they know what they're doing, and there was absolutely no detail, nothing about the criteria. And I was struck, as Councillor Connor was, when you mentioned that people are assessed in comparison to a national framework. So just as Councillor Connor was, I sort of thought, I have just heard that allegedly less people in London are considered eligible, and yet there's a national framework, and so of course, because the people who are assessing are independent, they must be assessing on the exact same level. So why on earth are the people in London so much healthier than the people in the rest of the country? It's really quite bizarre. But that was just one thing that struck me. And then I've got a couple of other things as well. So as we are allegedly lower than other parts of the country, I'm thinking that you must have it as a priority to sort of address, because I presume that it should be equitable across the country. So I'm hoping that that is a priority. So I hope you can just confirm that we are doing everything we can to address this, because we must be aware that we must be under awarding these plans. And then lastly, I didn't know anything about these. My mother was very, very ill. In fact, she couldn't stand. She had dementia. Every time she stood up, she fell over and she broke her leg, she broke her head. And I had no idea that they even existed, continuing healthcare plans. So they're not very well publicised, and I share my colleague Helena's interest in what do you need to do to get one. She couldn't stand up she fell over every time. She had an illness that made her fall over and she broke bones. And yet nobody said, oh, she could have had a continuing health care plan. Why not? I don't understand how it works, because I don't understand why so many people say, oh, social care, there's no funding in the country for social care. But to me, it sounds like there would be if this was applied.
Okay.
Am I wrong there?
Thank you. There's a couple of questions there, and then so if you could answer those, and then we'll take Councillor Donovan and Councillor Howard.
And first, I'm sorry to hear about the experience of your mum. I think so. Is it the leaflet you're talking about? I sent that was the patient information leaflet. Yeah, that was just there is much more detailed guidance on the NHSE website on CHC processes. I sent you something which was just easy to read. In terms of particularly with your mum and raising the awareness of CHC, I'm not sure the whole process, the detail of it, but I do think there needs to be a greater awareness of what CHC is for all health professionals, and I think I will work with the ICB on raising that awareness and come up with a plan on how we can do that alongside adult social care.
Okay, so there's a commitment there to try and raise awareness, and you'll come back to us with any plans the ICB have in that respect.
Very short, tiny question.
Very quick.
Yeah, just doesn't if this worked as it looks like it might be able to work, wouldn't it have huge cost implications for the system?
Yeah, likely. I do agree.
That's what it seems. Like might not be working quite as well as it could, but it looks like that might be a reason.
Agree.
Okay, thank you. So Councillor Donovan, Councillor Howard, Councillor Poku, and Councillor Peacock.
Maybe in relation to the last question, maybe if this process worked as well as it could, then what it does is identify real needs, and then it's up to politicians, either at this level or at a higher level, to make sure that the NHS has the funding to meet those needs. But again, I wanted to go back to what other colleagues have mentioned, which is the apparent unfairness of this throughout the country, and it's not questions you'll be able to directly answer, but they're questions that should be raised. The Nuffield Trust produced a report in June related to it, and they highlighted this, the number of people eligible, how it varies widely across the country. Unfortunately, they didn't mention London, but they mentioned other places. They said that in the year to March 24, eligibility, total eligibility, which is standard and fast track, range from 37 per 50,000 population Cornwall up to 301 per 50,000 population in Lincolnshire, which is a huge disparity. It'd be good to find out how many per 50,000 are eligible in Haringey. Just over a fifth of people who were assessed for standard in healthcare found eligible, but again, that varies widely. Only 7.3 in Gloucestershire and 42.5% people who were found eligible in Leicester, the Leicestershire and Rutland ICB. It talks about that this may be due to various issues regarding demographics, population moves, but unfortunately enough people didn't have access to any demographic data in relation to the people that were accepted and the people who weren't accepted. I don't know whether that exists somewhere else, but I suppose it does come back to what my colleagues are saying in relation to this apparent unfairness of the situation, and also that it is, as they state and other people stated, the whole process is very complex and daunting. And are there things that we can do together to make it less daunting and complex and to meet the needs of the people in Haringey? Because I am sure that there is need that's being met in different ways, but need that could be met through the continuing healthcare system. Thank you.
So just a reflection on your comments, I do see your point where there's a disparity between one end of the country to the other. I think I need to take that into consideration with the ICB and work with them and show what we are doing as for you guys as Haringey. I do know the absolute numbers for Haringey for the last couple of years has been around 600, which per capita isn't that many. So I assume the percentage is probably low, but what I can do is work with the ICB on that and see what can be done to improve that percentage rate. And if it's not being done now, why not? As a provider, we are somewhat limited in what we're doing as a providing assessments, and I think what we can do is make sure we're providing fair assessments and work with the ICB to make sure there's a fair allocation of funding to this. I'm sure it's not restricted because the funding is there for it, but actually I can take this back to the ICB and work with them on why this is apparent.
Sorry, did you give a figure for Haringey?
Absolute numbers, as in 600 patients last year. The year before was around 600.
Okay, and sorry, just to go back to my colleague's question around unpicking the complicated nature of this. Do just a clarification, if someone is deemed eligible, are they given a booklet that sets out really clearly that they can then discuss with family before they get or they start this process, just so they're really aware? Otherwise, it would be a bit sort of unfortunate to go blind into a process. You don't really understand what you're being asked.
The CHC currently contacts the patient and our family and discuss with them what it entails, and they send a leaflet to them. As always, there's always room for improvement, and actually to make accessibility easier and using easier language is always a priority for us. So I will ask the team to make that a priority for this year to see if they can make it more accessible.
Brilliant. I think having written information is really helpful, because verbally you say yes, 30 seconds later if somebody else is telling you something else, you've probably forgotten what that last sentence was. So especially in something like an assessment. Okay, so timing wise, sorry, Vicky,
I just wanted to make a comment that the national NHS digital data it doesn't individualise Haringey. It's produced as NCL as a whole, so it's very difficult to decipher what proportion is applied to Haringey from the NHS digital side. Just.
So was that number of 600 for Haringey quite helpful for yourselves, or?
The number will be across various things, fast tracks, continuing healthcare.
It would need to be broken down
Yeah.
further. Okay,
Combined,
thank you.
yeah.
Right, okay, that's very helpful to understand. Councillor Hall.
Thank you. If we could come back to the assessment of eligibility. So looking at it here, it looks like it's two-pronged process. One is by a professional group, the MDT, and the other is taking into consideration the views of the patient. I think the MDT, I mean, obviously those are professionals that work in the hospital itself. So although the process is supposed to be independent, you could argue it's not really truly independent that way. So that's just one point. Maybe you can come back to me on that. The other is the assessment of the individual's views. Now, I think if you were just coming back to Councillor Mason's point earlier, if you are an intelligent person who spoke English as your first language, then you'd be able to probably advocate quite well for yourself, or your family will be able to advocate quite well for yourself. If you were not able to do that, if English wasn't your first language, for example, or you had other personal circumstances that made it quite difficult to advocate, do you have something in place to advocate on behalf of the individual, for example, or somebody who speaks that language, things like that? Do you have something in place?
Yeah, so your first question there was how independent the CHC team are. They don't sit in the hospital. They sit independently in the community, and they in-reach into hospital to help support the staff with completing checklists and forms and support the family. And the ICB itself is much removed from the process itself. It sits independently in the centre. In terms of those who have difficulty, so if English isn't their first language, a translator can be provided. And for those who can't advocate for themselves, we do go through local authority for an advocate for that patient as well.
And do you let them know before? Do you that they can get someone to advocate on their behalf?
So you froze just for a second there. What was your question? Sorry.
I mean, if that process of advocacy, that the ICBU would inform them that actually that is available to you beforehand, before the process.
If it's determined they can advocate for themselves or the family, then one will be provided for them.
So when you say one will be found, are you asking the council to find an advocate, or is the ICB, have they got funding to fund an advocate? And is that a particular organisation that they're using?
The local authority, the social worker will arrange for an advocate.
Right, okay, so the onus is then to the council to use an advocate. So just because we've got Vicky in the room, so as the council, do we have that sort of capacity for the people that need advocacy?
So the guidance is really clear. The framework part of the eligibility states if people have that capacity and need support, that the continuing healthcare DST cannot move forward without advocate. I have no understanding of why we would commission a health advocate, but if we are involved in the case, then we would support with an advocate. But I'm assuming we're not involved in every case. There will be cases that we aren't involved in, specifically around fast track and things, and I'm not sure how that's managed.
Okay, so that's helpful to have understood that. Thank you. I think there's some maybe a bit further work on clarification really on who's providing the advocate and in what circumstances, who's funding that as part of this process. Councillor Book.
So mine isn't a question. I think I have got to declare something.
Yeah.
I'm not sure if it's really a declaration, but I was involved in designing an electronic version of these tools that I used. So I don't know whether I have to declare that or not.
No, that's fine. Yeah, that's good. Thank you. I'm sorry, did you?
It was just declaration. That was the, yeah.
Okay, thank you. Councillor Peacock.
Forgive me being ignorant on a lot of these things. And I don't know what the criteria is for dealing with people with dementia, whether it comes under healthcare or social care. and how they are assessed. I'm dealing with 2 cases at the moment. One is now in the Whittington Hospital because she'd been but she's so bad. She's now in the hospital, and her husband is absolutely distraught. He doesn't know how to handle it. And the other one is on his own, and we've just got him into an extra care home, but he has nobody to help him. So I generally go there, and somebody else goes there and tries to sort things out for him. He's getting extremely forgetful. He's even getting forgetful where he ends up in the street and he doesn't know where he's going.
So
He doesn't know where to go back to, or to go to my house, or to go to Stephen's house. And as you know, dementia is progressive, and it's getting worse. And I really think that he's extra his care, and it doesn't come under this process.
I think that's a very clear question. So Anthony, so what's the process if a councillor or anybody else, a family member thinks that a loved one or somebody they know might be, this might be a process that they would like to start? What's the best way that they can begin this process?
I think the first is because the CHC team need the information. I think it's best to go through the GP to raise that as a referral. I don't think we accept self referrals into the team.
What you've been getting, and the other ladies have been getting, is medication, and getting the medication stronger and stronger and stronger, and it doesn't have the required effect.
Okay, so I think Councillor Peacock, well, the answer there is that if there's concerns, they need to go through their GP, and the GP can refer them on for an assessment.
And what happens if the person is not agreeable to anything like that? But that's another thing about dementia. They're really obstinate. They won't do certain things. I mean, I take him swimming every week. I used to take the lady swimming as well, but now I say she.
I don't know the answers to that. Sorry, I'm not sure if Anthony's got any answers on that.
It's challenging. I understand this. I do come across dementia patients who are like that. I think in this instance they would have to be assessed whether or not they have capacity to make decisions for themselves. And again, that would come from the GP, and that would be an assessment need to be made. These kind of cases are the genuine need at the minute, and some of these are the gap in CHC which need to be addressed. And we know it's probably it's very highly likely going to be a problem that gets worse. But at the first point of entry would need to be through the GP for an assessment, and whether or not the person themselves lacks capacity to make decisions for themselves.
Okay, I don't think we're going to get much further on that one, I speak up, but I think we might come back to this another point. But I've got Councillor Donovan and then Councillor Brenham.
Just a very quick follow-up question to that. If somebody has been assessed and it's been determined that they are eligible and they've gone through the review process and it's still not eligible, but at a point in the future things deteriorate, is there a gap between when you do your first assessment and it's possible to have another look at that assessment?
Yeah, so once people, in the first, you mentioned there that if they did meet criteria for assessment, but then they did deteriorate, there are details on the assessment letter for the family to refer back again. So in that instance, the people can refer back directly into the service again for a reassessment, and they will take another checklist to see if there's any change in their needs.
Thank you, Councillor Brenham.
So it was following up with Councillor Peacock, actually. Would dementia count? Would dementia come under this criteria if someone's got serious dementia?
Again, it depends on that person's needs and what it is they require. So I couldn't really answer that. So it's not based on a specific disease. It's based on the person's needs.
That might. It's possible.
It's possible.
Okay. I've got a follow-up question that I'd like to ask. So, if someone's going through this process, they've gone through the checklist, they've been accepted to the assessment part of the stage. So, as part of that meeting, obviously, how do the people that are being assessed alongside either advocates or their family have access to what was said in that meeting. So are these meetings recorded? Is there a policy from the ICB around this in, structure? You were saying about the national framework. I'm assuming there'll be some sort of structure in place to say how these meetings are recorded. So if they're recorded, are those recordings shared with the clients and their family, the resident, who's actually having that assessment, or do these recordings just stay with the health professionals? And if they're minuted, how are those minutes shared? Are they shared with the resident and the family to ensure they agree with what's been said before they're finalised minutes? So do they remain draft minutes until that, or a draft assessment until that's actually been sort of agreed with the family? Thank you.
So by recorded, film and audio aren't usual, but each assessment is documented on a pro forma with what is said and what the needs are and with the decision tool. The patient or the family or the advocate are also sent these as an outcome letter as well, and processes of next steps are also included in that, whether it be it's been accepted or declined, and next steps if it's declined as well.
So there's no policy that says that the meetings could be recorded and shared, because I've come across cases whereby that has actually happened, and I understood from the emails that there was a policy around this, that actually clients, residents could request that the meeting be recorded and then shared. I think it was a little bit unclear as to how that sharing of that recording would then take place afterwards.
Yeah, it's not usual to record them on video or audio. A patient can, or a person can request this. There is a policy around this. And in terms of documentation, each health professional and each organisation will have a documentation policy on what is included and what detail. So generally, when the CHC assessment, I do know they take up maybe 15 to 20 pages. They're quite long and they're quite detailed. And I have seen them, so I do know most, if not all, the information is captured in that way, and it is shared with the family advocate. If people want to access our patient electronic patient records, they can complete a request with the organisation to release them to them.
So that doesn't happen automatically. You'd have to know to ask for that, would you?
And so the documentation, the letter will, with all the details, is copied. So whatever we send to the ICB and adult social care, the patient also gets a copy, the exact same copy we send in terms of written documentation.
What's the extra bit that you were saying you could request?
So we also record all decisions onto our electronic patient records. If people want for further clarity, they can make a request for that to the trust.
Okay, and is that documented somewhere so that they know they can ask for that? Because I wouldn't know I could have asked for that.
No, that wouldn't be included. But in terms of the documentation, if somebody contacted the team and said, "Well, I think some more things may have been said, and it's on your electronic patient records," the team will tell them that you can request this if you like. But it's not common to put this in our letters to our patients.
Okay, thank you. And a question on the NHS funded nursing care, which was on page 22 of the pack. So this is if you're a resident within a care home that's registered to provide nursing care. So if you haven't got CHC funding, but still some people, you don't qualify for that, being assessed as still needing nursing care. So how does someone know that that's another process which they could then access? I have to say I didn't know that existed, and I've been doing this now for some time. I genuinely didn't know that section existed. So how do people know that if one thing is refused, then they can actually apply for something else if they happen to be within a care home that's registered to provide nursing care.
So if the assessment was carried out by one of our nurses, that would be included in the assessment as well and an outcome. When patients from hospital are discharged into care homes, this is normally part of the process, part of the funding process to be assessed by the team.
And what's the figures like for this eligibility? So we've been discussing CHC now across the country and London. What are the figures like for this cohort of people? Are we in Haringey or NCL or London? We can widen it out to London if you like. Are we getting that same number of people getting that funding that we would do, say, in other parts of the country?
Yeah, it will be lower. I know that for a fact, but I actually checked any figures. It will be lower just because of the lack of care home provision around Haringey and NCL. It's a real problem within our system that we have a lack of beds available for these kinds of patients. So the numbers will be low.
But we would then, if people needed that, we would be sending, I mean, that's unfortunate, but then we would be placing people outside of borough or outside. So they would still be, you could still then apply for that criteria, couldn't you? Even though, say, they went to Bedfordshire or something, I don't know, I'm just making places up, but, you know, if we put someone elsewhere, surely they would still have that eligibility for that assessment.
Yes, and we can provide figures for that too.
Okay, thank you. Okay, right. I've got some recommendations following what we've heard tonight, but obviously I just want to check with the colleagues if they've got any other questions. If you take a pause for a moment to look around.
I have one more, but go round everybody else first.
I think we have, Cathy. So Brenda, you can ask me one last question.
No, I fear that while you were talking, it went out of my mind. That's why I wanted to just.
Okay. Well, if something comes back while we're going around recommendations. So thank you, Anthony, for coming. And I know it was very last minute, so I really appreciate the fact that you stood in so quickly and came and spoke to us this evening. I will just make some points though that I think we've heard today from the committee, and colleagues will chip in if there's anything else they wanted to add. I think around communication, I think there's been a really strong push for ensuring that written information is provided to families, carers, you know, anyone that's an advocate, and prior to any checklist or assessment taking place, so that they're really aware of what this process is and what the questions they're going to be asked. And so they're very clear going into that. I think also we need some more clarity around the process of the documentation. I think you've been very clear about what is normal, but you have said that there is potential for recording if needed. And I think maybe in some cases, you know, it would be really good to ensure that that is part of some sort of policy document somewhere, so that everybody knew who's going out to an assessment, if that was needed for a particular reason, that could be used and could be shared with the person who's being assessed. I think there also needs to be information really clearly laid out, and we didn't get it in the booklet, but maybe there is somewhere else, around how you challenge any decision. Because in your booklet there are very clear stages in the process. I didn't know we went up to NHS England, for instance, you know, that was a body that then went back down to the ICB, but at the same time I didn't know that it was escalated up. So I think if I had the pushback and said, no, this assessment has been, you know, has been agreed, I wouldn't have then known to ask for another 2 steps of that process. So is that clearly laid out in a written document somewhere and given to people at the outset? I think around the advocacy, I think it needs to be much clearer as to who's funding these advocates, whether it is the council's responsibility or whether that actually comes under this process, CHC process, so therefore it's the ICB. Sure that there's enough advocates around that, and that language is a barrier. I think you mentioned about getting the date and ethnicity of the number of people receiving the CHC continuing healthcare plans. I think Councillor Mason was very clear, and I think you gave a very clear answer. You would be coming back to us with some data around that, which would be really helpful for the committee. I think really the other part that we haven't really touched on this evening is if there is a at the end of the continuing healthcare process, there is an understanding that actually there's going to be joint funding between the council and the ICB as to that funding. I think it needs to be really clear that how much the person who's going to be receiving that care is actually being asked to contribute towards, because obviously some people will be getting it, you know, because they're eligible, other people will be needing to pay. So as long as they get that information and that's very clearly documented, that financial assessment is really clear so that people know what they're signing up to, so it doesn't come as a shock 6 months down the line when they suddenly get a very large bill. That'd be really good. I think we've got yeah, I think there's everything on my list as I wrote down as people were speaking. Is there anything else I've missed?
I have a point.
That's
Which was a very small point, was mentioned by Councillor Connor, but I do think that if we've got the facility in the modern world to record these interviews, we really should. Because if it's only a written record from the people who are assessing, they can, I mean, I'm being really devil's advocate, but you could just write your own personal opinion. Whereas if you've got a recording, that is what was said. So it might be interpreted differently. I do feel that if it can be recorded, I don't understand why it's not always recorded.
Okay, well, that's a request to the ICB, Anthony, so that's another one to add. And then the final bit that I was just going to be really clear about, and we did ask for that at the outset, was an understanding of why the figures for Haringey and how it appears to be London are very low in terms of the rest of the country. I think we've had various evidence given quite clearly at this meeting this evening around the disparity around obviously eligibility, or the fact that you know, people aren't getting the continuing healthcare funding in London compared to other parts of the country. And if this is a national framework, then it's really unclear as to why that's happening. You mentioned there's going to be some work done by the ICB around this, and you said you'd come back to us around what that work is. That would be really helpful to understand that. So yeah,
that's a very, yeah, I mean, I think the point around apparent unfairness and what some people call postcode lottery, right, vertical geographic inequality is very stark. And obviously we do need to have a lot more information in relation to Haringey. Why are the numbers so low? If it's possible to get some demographic information as well. Is it worse in Tottenham and other poor areas of the borough compared to other areas? And what can be done in order to ensure that people are aware of, well, first we need the data, and what done. People are aware of that, doesn't think what you say in relation to much clearer communications. But yeah, it's very how unequal this system seems to be throughout the country, and from what we're hearing, particularly in London.
so I think, you know, we finished on probably one of the largest parts of the main concern from the committee tonight is really about that numbers of residents in Haringey actually getting this funding, and concerns that the numbers are very low. And we really look forward to seeing what the ICB is going to be doing in order to ensure that we've got that equity across the country for that. So thank you very much, Anthony. It's been a pleasure, and thank you very much for coming along this evening. So
Thank you very much.
thank you. Thank you.
Bye-bye.
Bye. Bye.
Right.
We're going to go and have a gin and tonic now.
Thank you. Right, so we're now going to go on to the agenda item 7, which is Haringey Health and Wellbeing Strategy, which is on pages 19 to 38. Will McMorris, I think you're coming in to speak, and is anybody else online coming in with you this evening?
Yeah, so hi, I'm Will McMorris, I'm Director of Public Health. Maybe joined by my colleague Katrina, so she's a health person, been helping me with aspects of the strategy. She's actually on call for another part of the public health system, but she might be dealing with some other stuff as part of stuff before she has to. So she'll join if she can, be able to answer a question.
But before you start,
Yes.
can I just
Yeah.
read this?
Yeah.
You just
Yeah.
Can you just explain at the outset? I know you're going to give us a nice overview of it, but why we are focusing in on this strategy at this moment? We've got a lot of work in lots of different areas like locality teams and everything else. There's a lot of new stuff coming up in adult health and public health, and I'm just that big question at the beginning. Why now for a strategy, and what do you think it's going to add to all the other areas that we're currently looking at the moment and work's currently being done? Thank you.
Yeah, I'm happy to
Over to you.
start. Dominic, can we put the slides up? I know you would have read these, but the first question, so why the health and wellbeing strategy? So have to happen. That's part of the reason. And our current one is COVID. Nobody properly consult on it. It's not up to date. So we have to have a health and wellbeing strategy to guide our partnership working with the NHS. You're right that there are lots of other pieces of work that are going on. And actually, I'll talk about this a bit later. The goal is not to supersede those pieces of work, but capture some of the strong work that we're doing. And I'll talk about how some of those things are action plan. The other reason why it's important is because actually it gives us that longer term view, enables us to have to engage with residents about the things that we're already doing and what's important to them. So I think it gives us that broader view, which is beyond just the sort of locality working as one aspect, really understanding the issues. I'm the chair of the Health and Wellbeing Board.
I mean, I suppose I could be glib and say if we waited for when it was quiet, we'd never do it. It's always busy, as you know. And I think you're right to ask the question. It's a really good opportunity also to make sure that the borough vision that we're working on has connects with our health and wellbeing priorities. And as we try to do all those things that you're talking about, really important to have a structure that sits alongside them that we can strategically refer to.
So it should be familiar, but the Health and Wellbeing Board is a partnership committee. So all local authorities have them all local authority areas, and it's chaired by councillors, a cabinet member. It also has senior leaders from the local NHS and community and voluntary sector representatives. The board is responsible for the health and wellbeing strategy and understanding the health needs of the population. I suppose we had this item on continuing healthcare, which is looking at real mechanics and detail of how money is spent on the NHS. So that's not really within the primary focus of the health. It's something that we'll touch upon in terms of the resource question. This is more about our strategy for health improvement, reducing health inequity. As Councillor Desnes mentioned, trying to influence and link with the 10-year borough strategy. So as we go on, I've set a little bit of context in terms of what we can do at the local level and what is really we can influence only. So through London and national levers, and of course, we're aware we've had a change of national government, which will change that context somewhat. We've been struggling, I think, with the national political context. Many years we've been cutting against a very difficult tide. And if we move forward, there's a couple of slides just on health needs in Haringey. We can move on to the map, I think, which explains the challenges, inequality in life expectancy between the richer parts of the borough. Life expectancy now is broadly comparable to London and nationally. Men has been slightly lower, but actually we're seeing a good rebound after COVID, which is actually Keep going, Dominic. So you mentioned, we talked about the kind of moment in time. So actually, we took the opportunity at the end of last year to do quite a lot of engagement with residents. There had been quite a lot of engagement that's been done through Bridge, Health Watch. So our questions were, what matters to you in terms of your health and well-being? And of the things that we are working on, do these seem like the right priorities, and how would you prioritise with? And we went to a wide variety of forums to ask those questions. Really good actually to be present in some of those discussions and hear what people say. Was really rich, and we sort of triangulated that with the data to get our themes. So if we move on to the themes of our health and wellbeing strategy. So this is, we haven't finished the strategy yet because there's some action being developed, but these are the themes: housing and health, mental wellbeing, place shaping, and preventative health and care strategy. You mentioned localities, for example, our neighbourhood working. So that very much came up in the preventative health and care strategies theme. People talk about wanting to be able to access, whether it's a GP surgery, whether it's social care, close to where they are and have real clarity and access. And we know that's challenging with resources, but we are trying to address that through, for example, locality models. I don't think any of those would be a real surprise. So let's move forward. Then, as well as those themes, there are principles of how we work together. Again, this is a partnership. It's very much linked to the Haringey deal. So I think we've made good progress in really working closely with some of our communities in health and wellbeing and really understanding them. I think we've got a lot of work to do in that space, but I think we've made. I want to draw your attention to numbers 4 and 5 because during COVID, the Health and Wellbeing Board had a really strong focus and played the way in terms of leading on anti-racism. So the inequalities that were exposed during COVID. So that's always been a really important area of work for the Health and Wellbeing Board. So going beyond just catching inequalities and understanding inequalities, how do we actively challenge some health services and others? And then number 5, it's a bit of a link here to the continuing healthcare conversation and some of the questions that were being asked. The Health and Wellbeing Board playing a role in understanding the resources that are advocating for our fair shares in terms of health and care services. Let's move on. So where are we at the moment? So we've got those themes, and those themes are going to be our themes for the next 5 years. But we want to put a bit more meat on the bones and say what we're actually going to do in the first period of the strategy. And in this, we package got one example for housing and health. We're mapping this out for all the different themes, and that is existing work, but also there are any gaps. We're going to take the strategy with the action plans to sign off to the Health and Wellbeing Board, and after a year to 18 months, we will get an update on the action plans and the outcome. This is an example of just a subsection of what we've been doing is speaking to partners in the council, partners in the NHS about existing work that's going on, and this links to our corporate delivery plan, but also hospital trust plans, and also understanding any gaps. So that just gives you an example of housing, some very tangible actions about linking into bespoke home building, for example, and the health and wellbeing progress in those areas. But there are action plans for the other areas as well that capture some of the. If we keep going on, so that the governance is actually a little bit needs a bit of working out. So we have health and care governance at North Central London level with the ICB. There's something called the Integrated Care Partnership, which is where the leaders of the councils or the cabinet members come together with health and local authority leads to understand the collective health and wellbeing needs across London and our collective priorities, but also to understand what the local priorities are and how we can feed up to that. And I think that link between health and wellbeing boards and the ICB and the Integrated Care Partnership is articulated there, but we really need to strengthen that two-way relationship. And if we move forward at a local level, if we move forward to the next slide. I think we talked about this before previous scrutinies, but the got something called the Borough Partnership, which is a partnership of the key health and care organisations in Haringey and the voluntary sector. And this is about delivery of priorities around integrated health and care. Some of those priorities particularly fit into the prevention theme of the health strategy, and the Borough Partnership will have a key role in delivering the health and wellbeing strategy. And I'm going to talk briefly around outcomes framework, and this would be quite interesting to get your views. So we want to, in the first months of the strategy, develop an outcome progress. And similar things are happening for the delivery plan and also in North Central London with the NHS, looking at different metrics. The challenge with this, so say if we were to look at something like people dying young from heart attacks and strokes, the data that is reported on is normally about 2 years old, and we only have some of the levers locally to influence that, likewise immunisations or fuel poverty. Alongside those measures, which I really want us to measure and look at over time, we need to have some more kind of process type measures that will reflect the work that we're doing on a short-term basis. So we've got a bit of an example on the next slide of what this might look like. One area, so this is the healthy place shaping theme, and a couple of potential outcomes. So again, smoking prevalence. You get that in arrears, sort of about 18 months in arrears, the data from national surveys. We know how well some of our services are doing on a up-to-date basis, although they won't necessarily, like the smoking example, the number of people, this is only a small proportion of the current smokers, and there are much wider things at play. I mentioned government policy, hoping to see some government legislation coming in vaping. And then we also want to measure equity as well, because overarching aim is to tackle health inequalities and quite a different. There's another example there around this activity and some different things that we're doing around things like access to open space, accesses, and how. I think that's the end of the presentation, so thanks for bearing with me. Pretty welcome any questions and thoughts. A couple of considerations. So we've got 4 themes of the health and wellbeing strategy. So I was wondering if there's a particular theme we might want to revisit in more depth as we go. And then in terms of any comments on the themes as well, but also on the outcomes as well. So Scrutiny is going to play a role in looking at this strategy for the next 5 years. What would be helpful in terms of monitoring progress, both in terms of monitoring the actions and diving into particular areas. So I'll stop there. Thanks.
It's straight in the chair for this one. So I'm going to come back to that first question that I asked you, because we've got a number of what looks to be very strong sort of things already set up. So I mean, with the themes that you've got on page 26, absolutely, they're great. I mean, I thought, yes, absolutely. And I can absolutely see that as the strategic, that's the oversight and actually how we're going to deliver that. But are you asking that we then scrutinise something that falls underneath this? Or, because you've got the Borough Partnership, where you've got a very strong, so I'm trying to come on page, it's all on. You've already got quite a lot of, on page 30, you've got your links to health, wellbeing boards, the NHS and ICB, which is very clear. And on page, I've got 32 here, so I don't know what it is on 32. You've got your health and wellbeing board links, the Borough Partnership governance. So that's another cohort of strategic, which looks like live well, start well, age well, neighbourhoods and health inequalities. And then you've got the themes for this under your health and wellbeing strategy. So suddenly it looked like we've got a huge amount of different sorts of columns with lots of different ideas and where they're all fitting. And I think for me, I'm just wondering, I can see why you need the strategy. I think the themes that are chosen, I thought were great. I mean, that's just my personal opinion. I mean, I went through them and thought, yes, I completely see why you've got that. But then I couldn't quite see how that works in relationship with your Haringey Borough Partnership exec, because I can see on page 32 where that all flows, and I can see what your Health and Wellbeing Board linked down. But then underneath that, surely now you've got the themes, and then you've got how you the outcomes, and that's all going to feed there, and this lot's all going to feed up. So where does this all go? Is this all going to the Haringey Borough Partnership Executive with chaired by Andy? So I don't quite understand where this was all sitting when you started talking about the outcomes all going to be measured, because that bit where you said about parks, that's very difficult to measure. You know, the outcomes, I mean, good luck with that. That's very difficult. I don't disagree with trying to work out how you're going to do that, but I think that's going to take some time to do that. But so yeah, so just how does it all fit in with this slide here? And especially this slide then has all the themes, and then it has all the outcomes, and then all the measurements of the outcomes. Is that fitting into this, or is this amalgamating alongside this, or how does it all?
Yeah, I hear what you're saying. So on that slide,
yeah,
that shows the borough partnership governance and flows into the Health and Wellbeing Board.
Yeah.
But actually the Health and Wellbeing Board, the aim is that we'll capture other areas of work that aren't directly within the remit of the borough partnership, like the housing.
Yes. She's going to sit under this part of the section.
So some themes, so particularly the preventative health and care,
right,
and the mental health and wellbeing,
yeah,
there's a real direct link to the programme of work through the borough partnership. The healthy place theme,
yeah,
and the housing and health is a much wider, it's wider even than the borough plan. We'll need to bring in different parts of the council to report into the Health and Wellbeing Board, and they're captured in the corporate delivery plan.
but they're all going to go into this board here. That's
the borough partnership exec note that will just go direct, it will go through there. So it's difficult to explain, but if you, for each of the action plans,
yes,
is going to be, say, an action around housing, it will be where the governance sits and how that reports into the Health and Wellbeing Board. So, for example, the housing, a lot of that sits under the council's placemaking and housing board. So then we would ask for members of that board to come into the Health and Wellbeing Board. So that's not directly within the scope of the borough partnership. I understand it probably needs articulation when we produce the strategy about where these different routes are.
Now, sorry, I just saw lots of different, and I was thinking if I didn't know. I mean, I think I knew a little bit more, and I was just really teasing it out just to make sure it's really clear for anyone listening.
Well, I think that's about us being, when we have the strategy, being a lot clearer on different
and where it goes to,
where it goes to,
actually,
and who it's ended. So in the action plan, we've always got like a lead AD for housing and where that sits and how they're going to report in. But I think that's actually one of the strengths, and that I think we wanted to do something a bit broader to capture what residents are saying. Otherwise, we're operating in a narrow scope of just health and care services. It's a little bit more complicated having to reach into some of the wider determinants of health. Rest of this.
I'll stop because I've taken up lots of time. So I had some people's hands up. Sorry, I was trying to. So Beverly, did you want to sort of, and then.
No, I was just going to make a suggestion. I understand exactly what you're saying. I was going to suggest that we go and do a sort of bigger schematic, so to see how everything links. So I've got it on one page. I think that's doable.
Yeah.
Very large page. And
it will be, map it out,
Put out on the table. Thanks, Beverly. Yeah, no, that's very helpful. Okay, I've got already other questions, so I'm going to start this way down. So Councillor Brennan, then Helena, and then Councillor Mason, and then Councillor Toku. Yeah.
So my understanding was that you wanted our input on the metrics that you're going to use. You wanted our input on what you should look at to see whether the health of the whole area is improving, what we should focus on. Like you gave the example of focusing on smoking, which I thought was much more myself. And I was just going to say a suggestion. I wanted you to look at housing if you were going to, because damp housing, if you wanted to narrow it down, you could be specify damp housing, because damp housing is still happening, and I'm sure it's affecting the health of our residents. And we could just narrow it down to that, and it might actually make them solve that problem.
Okay, so Helen, did you want to ask your question as well, and then we'll take them in pairs, and then we'll.
It's me now.
Yeah.
Right, okay. Hi, Will. Mine are a little bit more detailed. Social isolation. You've stuck it under in your 4 categories. Excuse me, you've stuck it under mental health. And I don't understand why it's not under preventative. I mean, it's been proven that it's one of the factors for dementia. And I'm actually disappointed not to, you can put it in both places,
Yes,
but
yeah.
why isn't it under preventative? So that's my first question. And where is it on that governance chart on page 32? It's not even mentioned, social isolation there. This is a big problem it's for everybody, but for Haringey. So where is it there? My next question, so I've written these down because I'm very interested, you know I am. What has happened to the Ageing Frailty project? It was really going great guns, and then you moved, or not you didn't move, but the ICB moved the person in charge over to primary care, and it seems to have died a death, even though it was a pilot supposedly in the west of the borough. So I'm just concerned about that because there does need to be some focus on frailty in the borough. And last, but not least, I looked at your thing about green spaces and access to green parks, and why is it just about physically active adults? What's happened to the disabled? I mean, I'm actually surprised that, you know, we should be caring about people that have disabilities too. So sorry, there's an awful lot of questions there, but I'd love some answers, please.
We've got Helen and Councillor Brennan.
So Councillor Brennan, yes, so that housing is one of the priorities. So we're thinking about how we measure it. And actually, we haven't done that in the past. How we're doing management. The council is doing some work on that. So that's exactly an example of what we can bring forward. Much more difficult to do in the private rented sector than in our own housing, where we've got a specific programme tackling that. So that's another interesting area about how we would look at that in the private.
Good, because you just got to ask the people with their illness about the state of their housing, whether it's private or not.
Yeah,
You know what I mean?
You can, but in terms of having a system measure of how well we're doing and how well we're mediating those things. So yeah, but yeah, I completely agree that it's a really significant issue on the cake in the engagement. Social isolation, that came out really strongly in the engagement. It actually came out with people talking about their mental health and well-being, as well as that kind of prevention. It did come out in that content. But I agree, you could put it anywhere in the slide. And it is very important in terms of prevention. I think what's more important is that we really clear about the work that we're doing in that space. We have
page 32.
in the borough partnership show would be within the kind of age well space, but again, we can articulate that more clearly, and it will fit in the action plan.
I think I'd go out on the limbs. I think we should go in.
You should go. Right, okay. Yeah, yeah.
We should do what's
that early and in that. I agree with you.
Okay.
Sit in both
Yeah.
and
Never say
certainly
that
both.
achieve
But certainly, you're right, Will.
I would like to put it in both.
Yes, I think sit in both.
Link across,
And
yeah. And it
I
is.
think your point's well made.
And Helena, that was one of the things that came up most strongly. So we, again, if we're going to put this strategy into action, we need to have some plans. I know we've got lots of small projects that are working on that, but it's how we kind of strengthen it.
I mean, to be fair, I can't remember if it's 32 or 33. Don't think that's exhaustive as to all the things in age well, live well, or I mean, what's there on that? But agreed.
I don't know if Sarah might come and help me with the ageing well question, because I know there's a little bit of I think the question, Sarah, was about the specific West. Was it about the West Haringey?
But they did the pilot.
Yeah.
Yeah,
Was it the aging well more
I
generally?
know somebody's there is there.
Yeah.
yeah. I mean, I'm speaking on behalf of the ICB, so I'll follow up if required. But in essence, they obviously have been through a transition period. They are in the process of recruiting to a number of roles within their structure. They have filled one of the age well roles with a lady called Barbara Sopitan, and I believe there was an age well board meeting today. And through the steering group, there will be the priorities agreed. That frailty project is very much on the plan. There's just been a gap whilst they recruit to roles, but there is still work happening. It is still on the plan. It will get back on track, but I don't expect them to have some of those roles filled until September.
So can we have an update?
Yeah, I'll ask Tim Miller to provide an update to the panel.
That's an action. So
Yes,
you've got agreement and an action. Helen,
That's
so-
too much.
Okay.
Just the disability thing and the green space,
Yes.
please.
Yeah, so that was, the examples about us for illustrative purposes. Another key thing in the strategy around healthy play shaping is around disabled access, both across health and care services, but also in terms of our planning. So on the themes side, improving disabled access to local facilities. And one of the things that we want to do in the first 18 months is I want someone in my team, one of that we have trainees and junior doctors coming through the team, is to really map out with organisations like Joint Partnership Board and other representative organisations what some of the issues are, so we can understand parks, health services, what we can do through the local plan to enhance that. So that is a key part of the strategy. I completely agree in terms of the outcomes. Don't fear.
Just saying.
Yeah.
Some of the things that could be around that could be about path access. It could be about, for younger people, the right kind of play equipment that's adaptive and adapted to different kinds of needs. All those kinds of possibilities.
We also had, so I was going to say that the changing faces with the toilet provision, and that I think it's happening in Northumberland Park, isn't it? There's only three, one in the sort of, middle, one in the west. I thought Alexander Palace was where the west was happening. I've heard nothing since, and I don't know if it's happening in Finchley Park, if the change of places.
We can get you
We've got one.
Yeah.
There is one in Finchley Park already.
Right.
There was issues around maintenance of that, but there is one already.
Because
I
I
think
know
you're
there's
right about
issues.
NIC. Not sure about the third one. We
I think
right
that
back.
Lane Park is one of, I don't think challenge, that's down in, that's Tottenham Hale. I don't know, but we can come back.
If I can come in, Ali Pally, I believe, has gone live in the last couple of weeks.
Anyone's what to say?
Go live.
Go live. Oh,
Yeah,
excellent.
Yeah.
But that's really good to know, because I've been following that up for about 6 years now. So I think I didn't hear that, so it's good that that's actually happened. Thank you. So that's great. So I've got Councillor Mason, and then Councillor Poku, and then I've got Councillor Donovan and Councillor Peacock, and then Councillor Harris.
Okay. I've got a few comments. So first of all, it's about looking at soft outcomes and how you're going to do that. Because I think that the examples you've given are mainly of hard outcomes. So particularly, for example, the children who are waiting for a health and social care plan, the numbers on that's the hard outcome, which is ones that we are dealing with as councillors. Is that children are not children who get the plan are actually getting the support they need at the right stage. And those children and schools and parents can speak about the positivity of that. The lack of that then is also affects the soft outcomes for those children as well. So looking at that, I think is really important. The other thing I've noted, I picked up on the isolated loneliness issue, not just for older people, but also for example, new mothers. There are quite a number of new mothers in our area are single mothers, and there's nowhere for them to go to. It's really difficult to have the support that they need on an ongoing basis, both for the baby and the mother. So that isolation and loneliness across from disabled children through all the way. Obesity we haven't mentioned, and I think that I'm sure you've got these in all the lots of charts somewhere. But given the problem there is with obesity, and also freedom from violence, both for women, but also for young men, and in particular parts of the borough, for young black men, young Turkish men, or people of Turkish origin, that those are really key indicators. And I wonder how we're picking up on those. So that's one question. The second question is how we are making sure that we progress on the key issues which you've identified really well, I think. For example, housing, a key issue. How do we make sure that housing and health are going to be accountable to the health board? And I think this is partly following up on the question that you raised, but also how health and housing are brought together, because at the moment it's really very problematic, and really needs to be looked at as a joint enterprise rather than that separation, which, although I know there are projects, but it's still huge separation. So it's how these are rolled across everything in the council. And the other question is how you intersect geographical areas with this, with the plan. So it's all very well if people in one area, just say Stroud Green, have got fantastic things going on. But if there's nothing happening in my area, Bounds Green, or nothing happening in central Tottenham, then, you know, we might say, yes, you've been successful, but we need to know how we're going to make sure that there's geographical allocation of resources as well, and that the action plans are picked up locally, and then how people locally can feed back. So how you capture the local feedback, not just from each individual organisation, but from localities, and so how we can make sure that happens. Just a tiny little thing about outcomes, making sure that we pick up on compliments and how we pick up on complaints. So those as a general overview. So compliments mainly are to do with, and a breakdown of that, and complaints are mainly to do with that, and how that informs us and how we move forward. And when you asked about how we would focus on the strategy, and I think that really, it is how you frame it, isn't it? But the outcomes clearly are going to be the way in which we will be able to view and review what's happening, and those things that sit outside the outcomes. So in a way, I think it would be good for us to agree, not just on the outcomes, but also what sits outside them, so that we will know as a group, as a committee, how we will be able to monitor those. But I think it's, I'm really glad to see this. I think it's a really positive move forward. A lot of work has obviously gone into it. And so thanks a lot for that. And I think it could, if we can deliver on it, it could make a real difference in the borough.
Okay, so there's quite a number of questions there. So I'm not going to ask Councillor Perry to come up with those. I'm going to we'll just, Will, if you could take those all in one go, and then we'll move on to the other councillors.
Yeah. So I think the soft outcomes question, I think you were talking about plans, health and social care plans, or EHCP for children. So I don't know where that, because obviously we've got like a co-design group around that, so I'd be interested to find out what's already reported there and whether that's in the scope of health and wellbeing strategy or that for that particular outcome. But I completely hear what you're saying. It's like, how do we really understand the nuances of this? Just on the new mothers, we have got some quite innovative services, like there's something called ABC Parenting. I don't know if it's been presented here, which is accessible for by some really enthusiastic, excellent clinicians from North Middlesex. And the whole point of that is getting new mums in terms of peer support. I think you can access across limited to the North Mid, so perhaps we can circulate some information so you've got that as available. And it's exactly the kind of thing that we're trying to do, because you're right about the isolation. And then the obesity, that is within the strategy within Healthy Place, and we're updating our healthy weight strategy, which is a kind of sub component. There's so much work going on. It might again be something that we want to talk about more, deep dive into more deeply. Interesting, you talked about the community safety, violence against women and girls, violence, youth violence, violence for young men. It's not actually at the moment as one of the strong as we expected in the engagement, but we have got, as you're aware, community safety strategy, which it is a plank. So it is about making those links across with community safety strategy, where they're measuring lots of indicators around that. And the housing and health, it's interesting you mentioned that, like how we're working together. I think there's two angles to this. So one, I think the council's work is becoming a lot stronger. There's a real commitment to improving the housing stock that we've got and building new houses. So part of that is just influencing that to make sure that that new house building, although it's limited, we know it's limited in terms of what we can do, does meet health needs, and we're taking that into account, and we're doing all the repairs and things for damp and mold. The second point is around integrating pathways, which is really challenging, that health housing interface. I'm sure both you and Sarah could talk to that. We had a really good session actually with housing leads and health leads from the hospitals, as well as the ICB and council, to sort of work through what work we might want to do in that space. It's tricky. I think there's lots of different entry points into the housing system, depending on whether you need repairs, whether you're temporary homelessness, you know, so it's really confusing and really challenging. So trying, but I think it's tricky. And then you talked about the geographical components. Again, it's difficult for me to give a comprehensive answer now, but I really hear what you're saying. Obviously, we're doing localities work both in social care and through our integrated work with health. So again, maybe it's something that we can, when we bring those items and when we talk about those items, we can look at that kind of feedback. And compliments and complaints tend to go to services, specific services, and this is an integrated strategy. So interesting question about how we understand collectively where we're strong and where we're getting complaints. Housing is obviously an issue there, and mental health appearing in quite a lot of inboxes across partners.
Yeah, well, I think complaints all come collectively to overview. So at some point there is an overview, and I feel like, and you correct me if I'm wrong, Chair, but then all of us from the different services came because there's a broad spectrum of complaints, and we could discuss the different areas. So there's that kind of visibility.
I think does come
in that moment.
Thank you.
Could I ask a very small?
Sorry, I just want others to come in because you.
Okay, sorry, gosh, that's
that one, so I'm going to let.
Okay.
Keep it for the end if we've got time at the end. So Councillor Poku, and then I've lost track now. Who was next in the queue? Right, we're just going to go in that order. So Councillor Poku.
Okay, so my one, I'm looking at page 23, and it's the life expectancy. Because we've always been told that it must be on bus 41 going from Highgate, Archway down to Tottenham Hill, and it decreases. Just looking at this actual map, there are two wards that stand out. You've got Stroud Green and also Tottenham Central, where the expectancy for both males and females are lowest.
Mm-hmm.
I'm just trying to understand how Stroud Green, what's the reason for Stroud Green?
Yeah, it's really difficult to know. I mean, the numbers are really small at ward level, so you have to. I mean, the general trend is this east to west. So Stroud Green, I don't know. We'd have to look into whether that's a sustained trend, whether that's just you could even get just a couple of people, you know, which could skew it for that year. I'm trying to think, you know, whether there's Stroud Green or whether there's a particular population that would be affected, but I really can't think about that. Specific answers like that.
I think that's a really good question, and I think because I think probably people wouldn't skew that level of, because these are quite substantive figures here. So I would ask that, well, if you came back with a little bit more work on that, as to why that is the case, because that's, I haven't seen that. So
I was surprised. I was really surprised. I thought whether there was a pocket of deprivation.
Yeah, I think that would be, because we would.
Something that it's very high.
I have a theory, but I won't share.
Yeah, so we're getting into that. If you had, say, some drug-related deaths or something in young people, that would. But I don't know.
It's not a boundary change, is it?
But we won't speculate now.
I don't know, because I won't be able to look at the individual, causes of death in that. It may be more about understanding kind of trends or their particular demographics that we might want to look into.
It's just worth unpicking though, because I think that's very unusual
Yeah, because it'll be interesting to see Stroud Green and also the fact that Tottenham Central, for both male and female, is also low. Are you going to be tackling those kind of wards just to try and see how you can improve life expectancy? What is it? What are they lacking? Those types of things. But then the other ones is just picking up on what Councillor Mason said. I think the feedback is definitely important as well. It's good that it's a meeting where everybody comes and they feedback on it, because what I've found at times is I've seen that you've had surveys done, but if I wasn't a councillor, I wouldn't have even known there's any survey that was done on this. So it's a matter of, I think what tends to happen is the usual suspect are the ones that are being engaged and others aren't. I know it's very difficult to get everybody. I know it's quite difficult, but it's also what can we do to actually get people from more people, more groups, that type of thing. I think it's quite useful for that. And also obviously the ages of people. The other one, I guess, I'm not sure whether we can look at it now, but it's the council has targets for building new houses. I think Council Mason addressed the fact that we tried to get health and local authorities to work better together. But if they're building more homes, they tend to be building more homes in the east of the borough. It's just getting more and more dense in that area. So that also affects people's moods, because as you leave the area, it's just so gray. All you see is gray, 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 gray as you're going along. So that affects people. You can get depression as a fact, affects mental health and those things. So what can we do? I know the cost of housing in certain areas affects the reason why they build it in particular parts of the borough. But it's just addressing that and also ensuring that we don't have the situation that we had in Tottenham Hill, where they built so many flats but didn't have a GP practice for a long time. So it's just trying to also address those things. I know the way health is dealt with is changing. They try to change it and have people be seen more in the community than in primary care. But again, just trying to address those things as well and making sure that people are not enfranchised because of these kind of things.
Okay, thank you. So I know Councillor Sledge also wants to come back in.
Yeah, I just want to come in on that. I think there are a couple of principles of our engagement, because you're right, there's a day around always engaging the same people, not feeding back. And I think two principles really, I think, are you said, we did. So coming back when people have come back, when people have told us what they think, is to then go back and then have that opportunity to present. And for example, where people have fed into other wellbeing strategies, to go back and say, well, here is the strategy now in an active way. But I would say, well, I think we've done a lot of work to not just do the usual suspects, because what we know is you put it out, there'll be a certain set of people who will always fill in a consultation if they want to, and they can access it digitally. So I think what we've been doing is outreaching much more into community groups. And I don't think people are hard to reach, I just think we haven't always gone out into those spaces. So it's about, there are lots of networks, people are meeting every week in the borough. So I know, for example, the kinds of things we've been doing more is going to the Carers Coffee Morning, going into other community groups that are already meeting, and sharing what we're doing and hearing what they've got to say, just so that we exactly tackle that issue. Could I say something about greyness, even though Will might want to say some more? I think density, I think it's a fair point you make about density and greyness. I hope that we're not building any horrible greyness. I think that's the task of placemaking strategy, which is much more about what a place looks like and feels like, and about that infrastructure. Right, you touched upon the broader infrastructure, having the right health facilities, having the right community facilities, but just having nice spaces, having good green spaces. So the investment, you're right, there are issues in Tottenham Hill, but I think Sean could probably speak to it, that we've got a huge investment into the park there, which is about having a space that people can use and that will make their well-being, improve their well-being. So I think that's part of the challenge of placemaking, and is something we will be accountable for. It's how we make it a great place to live, rather than just a box that someone goes to every night.
I'm happy to talk about greyness. Off topic, but yeah.
That's right. Will, did you want to comment on anything else?
No, nothing. I think
Okay.
it's similar from me.
I actually did want to back up Councillor Focu's comment on the Tottenham Hill, and apologies because I'm not the councillor obviously there, but I did sit on an awful lot of planning and there's great big blocks are going up. I find it incredibly frustrating on the planning committee. And this is because the procedure and the way that it's done and the advocacy of trying to get more green spaces and more infrastructure in to be sort of green, like GP practices, etc. I found it as a councillor very hard to sit on planning because I used to come out very frustrated at the end of it. I didn't think as a council we had the ability to really push for better and in that. Now I might be wrong because I'm not normally on the planning committee, I was subbed in. So I think any work that you can do with our housing colleagues and planning colleagues around strengthening what we can ask for, I think, I don't know, I just think that'd be really helpful because I'm not sure. Anyway, I'm going to leave it there. But that's just an observation that I made.
Some of the work on the local plan, I think, might well help that too. I see Sarah's come in.
That was going to be my point. Thanks. There's a whole part of the local plan which is focused on health and the wider social infrastructure. So I think that yeah, it will be picked up as part of that.
I think it's a £7 million. Am I right, Sean? £7 million park going into Tottenham Hayes.
Recreation ground. I mean, I've gone right across the cricket pitch and the football pitch and everything. I'm really disturbed about it.
Right, well, there's obviously
Rolling back.
But I can't tell you the amount of high-rise blocks that told me that one park was going to be their green space, and I thought if one more developer tells me that park is going to be where all these people are going to go in, I'm like, well, standing seven. I should stop because that's a particular bugbear of mine, and I'm digressing. So, Councillor Peacock and then Councillor Donovan.
Mine is not going to be a question actually, because you very, very kindly mentioned on page 25, People's Day event, which is something that I started up 10 years ago. Okay, and that was my initiative. I do everything for that. I promote it. And I organise it and I do it all, and I get a lot of people coming along. And as you know, I also run a pensioners group. I've got 350 members. They're coming to 200 are coming to a free tea party in August. They come twice a year. I take them on day trips and I take them on all sorts of trips. And I'm now doing bingo for them every week and all sorts of things. So I'm actually physically doing something about isolation. And I think I deserve a pat on the back.
Your word is recommended.
Okay, so that's a comment.
Maybe measure the outcome.
Yeah, no, let's.
Laughing, but you'll have before you get home, the robots will be full.
The outcome is definitely positive.
Exactly.
We see less pension movement for trips. Yeah.
Yes. Okay. Well, thank you. That was an excellent addition to the meeting.
I'm actually doing something.
No, I completely hear you. So that's enough.
So thanks, and I think this is really timely actually, and thanks for bringing it forward. On your first page, you mentioned your 3 aims: to improve health, prevent illness, and reduce inequality. And then obviously the rest is what priorities, what themes come out of that, and how we can, across all services, this wellbeing health strategy should inform everything that we're doing. I mean, in terms of housing, there are some levers that we have and some levers that we don't have in terms of private renting and damping private renting. We don't necessarily have those, but as part of housing enforcement, looking into homes of multiple occupancy, I think already well-being and health is at the forefront of people's officers' views when they inspect those places. But the strategy will make sure that it is. And I'll be the third person to mention the local plan, because I think that's really important. If you're a planning officer, on the planning committee, decisions are often made because of the local plan, but the local plan is being drafted at the moment, and hopefully this well-being and health strategy will inform that as well. And as yes, you're right that there is a certain amount of I mean, some of the things, if a private developer comes with a plan, what we try to do is maybe mitigate their worst excesses. We always mention health, we always mention green spaces to try to make sure that it's not just people's homes, but that they can live in, that they have sheltering, but actually the wider thing, not just give people, you know, a table to sit at, but a rose in the vase on that table as well. And that's something that the health strategy should. And I think what we're doing, you mentioned it here, is we're building blocks of support for people. And there's some of those blocks we have some control over, some are controlled by the NHS, some are by nationwide national government, but then there's other ones that we don't really have control of. You know, we can't, people might either have support from their family, or they don't. But I think if we build this process sturdy enough, if people lose one of those blocks, if they lose a block of health through COVID, or they lose a block because they've got a bereavement, is that whole structure strong enough to continue to support them? And I suppose, and this isn't necessarily a party political point, because I think all councillors have contributed to it, but this graphic that's been out recently about the first couple of years, I mean, this actually does have the image of blocks of, and I think if you go through all of these items that happened over the last couple of years, we can see where health and well-being is already part of that. I think we need to make sure everything we do on the council is going to be part of that health and well-being. The other question is where we fit in as the scrutiny board. You know, what role do we have with all the other in very important parts of the council and co-production, etc. What are the metrics that we need to keep our eye on and keep looking at? And that's not something I've got an answer for immediately.
Excellent, thank you very much. Is there any responses you're looking for particularly? I know there's comment and thoughts.
Yeah, I suppose where are the gaps at the moment? Where do you think that we could improve our health and well-being in terms of decision making? Council.
I think some of those things that we talked about having kind of clear governance routes and clear plans about what we're doing in those other parts of the council that influence health. I think it's happening because we're influencing them, and I think they're starting to be articulated. But the strategy will help that in one place. I think something around understanding progress and understanding different communities, like how we're doing in different communities, would be another one that we're trying to address through our kind of locality or targeted work. And then more generally, the challenges there are resourcing challenges which are across all different organisations. That's more of a kind of influencing piece, I think.
Could I say something on that? I think it's always, if you look at organisations, it's always really, it's more straightforward to be really good at a thing, to be really good at building houses or making nice places that look nice, or caring for people. But I always say, and you've heard me say, the magic happens when those things work together collaboratively. And I think we are moving in the right direction, and some of the principles of Haringey Deal will help us deeply understand communities in every part of the council, for example. But the more constrained we are financially, the more pressure there is, the more constrained we are on resources, the harder it is to collaborate. We just don't have as much spare time and space to think. So collaboration, the more collaboration we have, the better off we're going to be in terms of some of these outcomes not achievable alone. So that's, I think, one to watch, isn't it? How well we can do that while still keeping all the other basics spinning.
Okay, that's fair.
Thank you. I'm going to come, I think there's a lot being discussed so far on housing, improving mental health, well-being, health shaping. So maybe I'm going to focus a little bit on the prevention side, maybe my hat as a doctor. And also I'm just thinking going forward is, how does this strategy fit with the strategy of the new government coming in power? And I think just looking at the discussions that were had prior to the elections, the big focus of the new government is going to be on prevention strategies, right? Because that will essentially improve the health and well-being of the nation, but also maybe in a sense help with the reform of the NHS and reduce the costs that we spend on the NHS. So my question, I think, to you is that looking at the causes of death within our borough, I think the big cause of death here we can see is really cardiovascular diseases. So the question, and in cardiovascular diseases, I mean, so just my Dr. hat on is in terms of hypertension prevention and how we identify that early and prevent that, and how actually that affects disproportionately certain communities in our borough. So I think it fits in with your strategy. Look, actually, if I was going to focus on specific things that could be potentially measurable and has huge impact on certain communities, I think that's where our focus should be. So I would say target cardiovascular health disease, particularly hypertension, and how we measure that. So I would say one measurable will be like, how do we get this community to come to see their GPs at age 40, for example? Like Black men are coming to see their GPs at 40 or 50 to get their blood pressure measured. And how we then, and if they need treatment, are we doing all of those things to prevent them from cardiovascular disease? And similarly with cancer, what are we doing going out to the community to essentially increase or improve the awareness of breast cancer, for example, in certain communities? What are we doing to engage with them and improve screening outcomes for these people? So those would be, I would say, very tangible, measurable things that I think, if we were to focus on, almost certainly improve the health and well-being within very specific communities, and overall, actually, you would see improvement here. So I think that's maybe a little bit that I would like to say. And there was maybe one comment about smoking in adults. Look, I think we can see over the last 40 years the really good work that's been done in this country, particularly the Western world, actually, to reduce smoking across the population, right? I mean, huge numbers have decreased, and for the first time, actually, and for lung cancers, it's not the smoking types of lung cancers that are actually, that's only plummeted, right? It's adenocarcinoma, which is the non-smoking related lung cancer that have gone up. So for me, is vaping. I wonder whether actually, when you start measuring this, when you say smoking, are you going to include vaping in what you measure? Because I think when we're saying that, look, actually, it seems supposedly safe, but this is what they said about smoking 100 years ago, right? We don't really know the potential adverse outcomes of vaping, and anecdotally, we see cases of nasty cases of vaping in hospitals, and whether I think we should include that, because whether people who vape then go on to do other things. So I do hope you'd consider putting that as something that you would measure. Thank you very much.
And not just the disposable, but the one-off, but apparently there's some problem with it being added to the canister, the reusable ones, now the refillable ones. Yeah. I can't remember on my assistance program, but there's something horrible that's going into those now, and I'm saying they've got huge health implications. So anyway, well,
there's quite a lot there. So the cardiovascular disease and cancer, that's some of the kind of basics of public health. If you look across London, public health, we used to sit in the NHS and we used to commission cancer screening and immunisations, and since that transition, it's kind of gone down. It's one step removed. There is work really to improve immunisations and cancer screening. We do need to work really closely with the NHS, and there is a cancer prevention strategy for North Central London. I think there's a lot more that we can do, and that will be part of the kind of integrated care partnership strategy. We've also got a plan on heart health, which we're starting again across North Central London, because it does depend on the NHS as well. I feel like I could talk for a long time and almost have another discussion on those, but I do agree with that. And there is some work in place, particularly on hypertension actually. And I also went to a meeting this morning, which was in London. There's something called, which is going to be focused on cardiovascular prevention across London, led by NHS and the regional public health director, Kevin Fenton. So it's how that kind of cascades down to it is. So that's where we'll link. So yeah, that'll be in the strategy action plans particularly. And then the smoking and vaping, again, I feel like we could have a whole discussion on that. I actually think smoking rates are higher than one would expect in Haringey and other boroughs. So I don't think that's gone away. And then vaping, we need to understand that a little bit more. And that's where there is this clear link to national legislation, which was like regeneration, and they're going to tighten stuff around vaping as well. I think measuring that is more tricky, so I don't know what measures we have. We have a school survey we do every 2 years. I think we've got a question around vaping there, or we'll certainly be adding one in, so that will give us some local data and understanding. Yeah, it probably needs a longer discussion, but health issues that are still causing a lot of driving.
I've got Councillor Fogarty coming in, I've got Councillor Kuznets, and we are coming to the end of the time, so obviously I'm going to be summing up shortly. So, but
it's just going on the smoking part. So a lot of the hospitals, they do, when you attend, they do ask smoking questions. They could be just adding, do you vape? Yeah. And the same as when you go to the GP and you're doing health questions, they ask you, do you smoke? Do you vape? It's those kind of simple things that you can actually capture information. Yeah.
Yeah. I mean, I was just going to add a few things, which are, what can we do? And you rightly say that prevention is high on the government agenda. So good that in our strategy we've got a whole area there, because then that meets the mission. So we're ready. And do we have a really good examples? I think the things that was talking a little bit about the mid-range. So I'd break it right down to the really good community examples. So an example of things we can do in Haringey, we are doing, are, for example, supporting Chestnuts Community Centre, who've run the Black Community Health event 3 years in a row. It's not lots of money, but we've been able to support it one way or another with partners. And why? Because they've had around bowel cancer, around cervical cancer screening, and we did a council with health and women talking about the importance of cervical screening. So those, I think, are really concrete examples. And I think that speaks to the issue of government mission London-wide, the local authority, and then what can you do tightly in a local community that can help people take control of their health a bit more, and that's really practical. And flipping what you said to how can we get the XYZ person to go to the GP, or how about how can we make sure that when they go to different places, they encounter it? So they're in the pharmacy, really good community pharmacies, and we know that people like going into them, they speak often community languages. Not all, doesn't work for everyone, but having those different kinds of options, ways that people can interact, but on the ground in the community. And I wanted to say something about vaping. And I was going to glibly say, actually, they did know about smoking, and the producers suppressed the information, didn't they? The commercial entities. But I think you're right about vaping. But the national strategy is about smoking and vaping, and so will ours be. And we're at least beginning to do some work ahead of that curve in public health, and actually going out and talking to some of the businesses who might be selling illegal vapes or selling vapes illegally, which is different. And we've had lots of good feedback from schools and head teachers who are talking about the issue for young people. So I think you're right.
What Will said.
okay, just very quickly, because Councillor Mason also has got a hand up. So is that directly to what Will's just said?
Yeah, it's just directly to what Will said about the million hearts, which I understand is a target of a million less heart attacks and strokes. I mean, could we divide that and have a target for Haringey? Less heart.
Yeah, I think it's reaching a million people. A million heart attacks and strokes would be. Yeah, but I don't know what they'll do in terms of targets, but that would probably link more to our heart health work. If you reduce identify people with blood pressure, how many strokes, heart attacks will it reduce? But yeah, I don't know.
I want to say smoking is very prevalent in some of our communities who are the most vulnerable.
Yeah.
It's this big issue for us. And actually, some of the smoking rates in smaller communities are quite shocking.
Yeah. If you're worried about life, you have a smoke. So if we stop people being so worried about life, maybe we can.
Councillor Donovan. I've got Councillor Mason.
Thank you.
Thank you. Yes.
So this was about coming back to the community safety strategy and violence and the issue around trauma and how that impacts so massively on people and families and etc. So thinking about that and then thinking about what we're just talking about, hypertension, and how important screening is. I think the other bit that we mustn't lose sight of is the causes then of hypertension and how we intervene. It's not just about screening, it's also about the issues around alcohol, exercise, weight, etc. And anxiety and stress, which links me back to the community safety strategy and how our strategies need to be really focused as well on not just individual health, but community health and well-being and how we address that. That does concern me, that we don't have enough community places, community centres. We don't have enough places where people can share information and ideas. Just a tiny anecdote is because I'm very involved with Bound Green Food Bank, and we have over 350 families coming every week. So, but people queue up for about 4 hours to get there, to come in. And when we talk to people about why do you queue up, you don't need to, because I like talking to other people. Because this could mean standing outside in the cold, in the heat, in the rain. I like talking to other people. And the problem is we have nowhere that those people can go and talk, because they haven't got the £5 it costs to get a coffee and croissant or whatever. So I think, the big circle needs addressing as well, which is people need somewhere to go that they can mix with each other, and then information will be shared and people will have better health and social outcomes from that as well.
Okay, right, well, thank you. So you've got quite a lot out of us today. So I'm going to just quickly round up what I think I've heard, and obviously other councillors come back and add to anything that they want to. Then moving on to Councillor Sneves for Q&A session. So thanks, Will, for bringing this. I have to say I'm really grateful for Roger A3 sheet of paper where this actually fits, because though I absolutely thought this was great, I wasn't quite sure how it was all going to fit together and who it was going to report to. And I think when you get down to more the granular details, when you're going down to the outcomes and the monitoring of it, where that sits within the structure you've already got. So I think for us just to have the clarity on that. I think really there's a question for me around the bit. We saw a couple of areas where you were beginning to say how you wanted to monitor and, looking at outcomes and how you're going to monitor those. We could already see the problems because of the ones you chose. I think green spaces and around how, that trying to work out how that health and well-being is measured as part of people accessing green spaces. So I think it's a bit more clarity around what you're actually looking to realistically be able to monitor and influence. And I think my next point is around how within this your partners, you're working with partners. Now we touched quite a bit on housing today, around the local plan, around that new local plan strategy, how you're working with housing colleagues, how that is quite complex, but actually what your realistic outcomes from that you want to achieve. Because I think at the moment you've given us a very high level, which is fantastic. It's a great time. We love it when you come to scrutiny with a very high level. But until we get that granular detail, I think it's quite difficult to sort of see how that's all going to pan out. And yeah, I think for me, it's around the community engagement, but also around the partnership working. because we've got a lot of partners already mentioned within this strategy, and how that's actually going to work in reality. And I think you asked us for our thoughts on that. I mean, to be honest, I don't think we can give anything a little more specific, although people have been very specific to me areas of, that they want to see focused on. But I think until we see it sort of fleshed out a little bit more, I think it's a little bit more difficult to try and work out, because from this bit, I still couldn't see where the groups we've currently got, like our joint partnership boards and different parents groups, reference groups, how are they fitting into this, or are they sitting still within, the other areas that we currently crossing over, and how they're going to feel where they fit into all of this. And I think it's going to be really helpful to get that clarity on. So I think at the moment it's great that you've come to Scrutiny with it. I hope we've been helpful in giving you some areas that we are concerned we think would be great to focus in on. But really, I think it's just understanding the detail of how that strategy is going to translate into measurable things that will make a difference to our residents. I think is that next step that I think Scrutiny would be really useful.
It has been useful because we're going to take the Strategies Health and Wellbeing Board in September. So what I'm hearing from this is just real clarity on the governance, and that's something that we can put in. That's the drawing the confidence diagram somebody. And then also the outcomes, had some ideas, and we don't want to have a really large outcome set, so it will be quite a focused outcome set, and they've got some ideas from what's come out of the discussion today, and clarity on what we're actually going to do in the first 18 months, which we've got longevity once we take it health.
I think that'd be really helpful. Let's just check with my colleagues.
Yeah, I just wanted to ask a question in relation to scrutiny, because obviously when Councillor Basnett comes here, we can ask her, how are you taking into account the health and wellbeing strategy in your work? As an obvious answer, you take it's part of your work every day, but then also will other scrutiny boards, will the housing people be able to ask the couple of cabinet members in have responsibility for housing and placemaking, how their work is informed by the strategy, an environmental scrutiny panel as well. I think that's something we want to do. Is each scrutiny board has this well-being, health and well-being strategy, not just this one, because obviously we're very well connected with health and well-being on this one, but it has to spread to the other two as well, and then also the
we have them in. Anyway, that's thoughts that
well, we could interrogate the member for housing.
we could have more focus. But anyway, those discussions, but that's a really good one to raise, really, about how scrutiny works effectively, so that we're not duplicating, we're not asking one set of housing and also asking that same set of questions. So I think we need to be much clearer about how we're working. So Dominic, I'll leave that with officers to sort of mull over as well as an action for us in scrutiny.
Maybe you want to direct that to your vice chair, you Scrutiny, you and Matt as the chair could discuss that.
Yeah.
My only sort of observation about it is that we've had a lot of talk. Is the word tension or what have you before you? This is that obviously on other panels, what we've got is a group of people who know a little bit more about that area and about the work that's taking place and can connect that. A bit harder if you have to start from scratch when we don't have the knowledge within this group of the housing or some of the environmental side.
But I think it's just having it on our work programme to understand that could be something that we might go as guests to another panel, sit in and hear what they have to say and maybe ask some questions. Okay, so thank you, Will, for bringing this to us today. It's really helpful. I think I'm a tad clearer now, but I shall look forward to that unpicking of that whole process. And so we won't talk about bringing it back to scrutiny, because often we say, well, when's a good time to come back? But I think there's quite a bit of work. My understanding is you're going to Health and Wellbeing Board in September. The Health and Wellbeing Board is the area that you're normally going to report into on this.
Yep.
Okay, so I think what would be helpful to hear back from you is if there's one specific area say it's housing, whatever it is that you think actually we're really focusing in on, and actually it'd be really great for Scrutiny to sort of come in and have a look at that, maybe through OSC, because it affects 3 or 4 different areas, or, you know, I think we'll sort of leave that with you, but I think it'd be really helpful to get a steer from yourself around when's a good time, because obviously we're not going to take another report, we'll be looking at something very specific next time. So, but it'd be great to get a report back from the Health and Wellbeing Board around the governance structure. So if we could be linked into the papers that goes to the Health and Wellbeing Board, so we see that governance structure, that'd be great for the panel to see at that point. So one last recommendation.
Oh, no, it's not a recommendation. I was just going to make a comment. I find it really interesting. I want it to come back to us. I'm just saying.
Well,
I feel it's relevant to us.
Well, I think
Totally
it depends where it's going. So it's going to
Totally
Health and Well. It's yeah. I don't want it to go to too.
Sure, it's not going to be never mentioned again. I'm sure part aspects will come back. Anyone, you can attend Health and Wellbeing Board as well if you want more and more detail on each of the areas. That's what I'm saying. So I don't think we're going to cover and do it justice if you think about us diving down.
I think we'll see the governance structure because the papers goes to Health and Wellbeing Board, and then based on that, you know, we can then look at it as a committee.
I mean, the other thing is we will, where it's structured after a year to 18 months, we'll review how we've delivered against our action plan. That would be a good time to come back as well as if you wanted to. Yeah.
Yes. Yeah. Okay, great. Thank you very much. Right. So, questions. So, Councillor Snaps, you're in the room. You've got the air conditioning working, which is great. Excellent.
Do something at least. I don't know. We don't.
We don't know. But it's now back on again. So, which is great. So the next agenda item is obviously cabinet member questions. Councillor Snaps, do you want to give us a brief summary of what you're up to, and then we'll open it straight to the. Well, we've already got hands up and we haven't even said what you're doing yet. So
I'm not going to talk for long. You'll be pleased to hear. I'll wait for questions. Only to say, I think, because a few have alluded to the national context. I think one of the things that's really important is to think about that alignment between local government, regional government, and then national, and think what I've been encouraging everyone to think about, and we're trying to think about is well, you know, what happens at each level, and what we described a bit already, the kinds of things we might be doing, Chestnut's Community Centre, versus what might be happening at national. Have the thread between those things, and how we might fit into some of those missions. I'm really pleased that prevention and intervention is strong. I know Bevan really is. It shows that some of the work that you're doing, Beverly, NODAS and others, has cut through, because I think that's the thing that naturally can be sacrificed when there's a lot of pressure in delivering services. So I'm looking forward to seeing a bit more on that and understanding how we can help. We can help. We'll be delivering, but how that can help us deliver, I suppose. And so I think that's important. I'm also spending a bit of time thinking about partnership at London level and also between local authorities where we have common challenges or common goals. And so really micro examples that we now have shared work with Enfield, who works with the Bulgarian Gypsy Roma community. That's a really small little microcosm of an example for a community that really needs a lot of support. And we've begun some work locally with a local authority because we recognise as shared aims, values and objectives as well. So I think looking at more projects like that would be helpful. And looking on it.
Okay, right. Well, thank you very much. We've talked a lot about a wide variety of subjects tonight. Helen, I noticed we went straight up with your hand. Does anyone else want to sort of put their hand up at the moment? So we're going to wait for Helen's question.
Oh, all right. I have the floor.
Get the lead.
Okay, so I have two very different subjects. The first, obviously, you'll understand that I have an interest in, and it's about the Joint Partnership Board, which is a unique organisation. There's no other one in London at all. So it's, Haringey's quite forward on this particular one. There's some issues about its future. It's done good work. Let me just remind you of the COVID survey report, the low traffic neighbourhoods work it's done, and the safeguarding work. So it's not a useless organisation. That's what I'm saying. I wanted to have a view from you about how important a JPB structure is going forward, and how the council feels about that. I don't want to get into too much detail, but I want to look at the overall idea. So that's my first question. If I could put the other one, which is very different. The amalgamation of the North Middlesex with Royal Free, which has lots of deficit, I might add, and the North Middlesex, which has the largest A&E in London. I wondered how involved Haringey Council had been with this and how they will monitor the performance. There you go, there are two very different questions.
Really different questions.
Yeah, very. You should know me by now.
Yeah, no, we do, and we like it. It's no point being here if we're not going to have those kinds of questions. The joint partnership board. That's an easy one for me because you're right. Haringey was ahead, and I think that it's a really, really important. What would we call it? Structure program. Structure. You said very explicitly. I wrote it down. A view from me on how important it is. Very important, but really important that it works well and that it brings together as many different and shared voices that can participate. You know me, so you know that I'm interested in the fact that there aren't hard to reach people. There are just people we haven't gone out and reached. So we should to make sure that we're doing that. My understanding is people who are more technically able can qualify, but my understanding is we've been through a process looking at how it's working and saying, okay, what could be better? That aligned with some of the other issues we've been looking at. We've talked about making sure that people have the right training and the right support and things are resourced from. So that's my view.
Okay.
I'll let people come in on that one. Do you want to do that now?
Yes.
I'm happy.
Thank you.
So I'm not going to add a lot more, but just to reiterate, re-emphasize the importance of the JPB. We, as you're aware, Susan did a review. She's now handed over to me. I'm the lead for taking the next steps in terms of conversations with the co-chairs and other sort of reference groups. And it's so important that we invest in some resources to, there was a recommendation to get external facilitation to support the next steps so that we work together. So we've already engaged that next step. I think we've got a meeting in the diary.
In August. I'm not sure what the agenda is for that one.
It's about next steps with the JPB review. And so community catalysts won't be at that meeting, but I really want to talk to you about your understanding and reflections on the review. Obviously, you'll have my reflections, but then there's something around the meeting of minds and how we go forward. And I think that external facilitation is really important in terms of taking that forward. So I'm going to talk to you about the conversations we've been having with community catalysts. There's some, discrete pieces of work, of which the JPB next steps is the umbrella piece to take forward. And it's so important to me. I'm investing a lot of my time in
I'm grateful.
Taking that forward. So
just to really be sarcastic.
No.
Beverly's in charge.
It is really important.
Never fear, Beverly's in charge. And those of you know me know that I've worked in participation before, so I'm really passionate about it. But I also think getting it right isn't always easy, and that having external people can help do that and getting the right skills and making sure people feel built up and supported by it. Sometimes it cannot be like.
North Middlesex.
North Mid.
Yes.
Yeah, well, the chair will permit me to say this has been rumbling on since we were on joint health scrutiny and I wasn't a cabinet member. And it was controversial and tense now. Then and it is now. Royal Free have reduced their deficit since then, interestingly. I think we're probably, it's fair to say others here in the room are probably more directly involved. Say I haven't had briefings. And I think Joss has too. But of course we don't have a say, they don't report to me. And how can I put this diplomatically? It's not something that we control, but we can monitor the impact to residents. And probably one of the best routes, I'm not saying, but is just because actually sometimes you have more space and time presented to you, and sometimes the presentations and the briefings I have are not held in public that way. But I don't know, Sarah, if you want to say anything.
Yeah, I was just going to mention that we have had some oversight through the Borough Partnership Executive, with a commitment that colleagues in those partner organisations would come back in 6 months, and that will be due in the autumn. So there is, I think, the formal oversight as outlined by Councillor Dasnebs, but we do have that strategic oversight through the Borough Partnership Executive as well.
Just to add to that, just we mentioned, so we've got a paper coming on the increased merger partnership, whatever its current term is now, and that's coming in September to the jobs. So it's one of our main agenda items. In fact, normally we have 3 agenda items, but we've cleared the decks and we're only having 2 agenda items, because that's going to be a substantive item coming to the jobs. And as you know, you've got 10 councillors, 5 boroughs, all systems asking questions. So yes, there'll be a lot of discussion on that from the council's perspective.
This it's an issue you and I have discussed when we meet regularly. So, but do I feel as acted on it, if I'm truthful, as I might have been about some of the other bigger issues that have been taking place in NCL, changes to return to service, for instance? Probably not, but that might be as well, because we had 2 elections in the midst of all this, and they haven't been able to spend time giving me briefings.
What worries me is that they don't seem to have looked to hear from partners, from other people, what their feelings are and how they're going to interact in the future. That when Maria was the CEO of North Middlesex, she fought very hard not to be part of the Royal Free, and I'm a bit worried, I would say, that this is going to happen. We do think we need to keep an eye on it.
Well, we're keeping an eye on it, jobs. That's all I'm going to say. Yes. So
noted. Thanks for raising it, and I'll go away and think if there's anything more I could or should do, and I'll have a chat to the team on this.
So Sarah's got that.
Oh, Sarah. Oh, hello,
Well,
Sarah.
Hello. I was just going to add that's not the only merger in this space that the panel might want to keep an eye or a view on, or just will. So the North London mental health which is currently sort of a partnership arrangement. I think there are discussions about that becoming a formal partnership, and there are also other discussions with the WIT. So just for completeness, it would if there is anything required on that, then we can work with health partners to provide an update.
So the UCLH and the Whittington is also coming to jobs. You'll be pleased to hear. So we're taking
health one.
We're taking that one as a later date, because their plans aren't as well formed at the moment.
Yeah.
And the mental health one, we are taking this pancreas item. We're taking those briefings at the moment through the JOS. So all the councillors are receiving briefings because they haven't got that final substantive piece to come to the JOS. They're still in that negotiation stage at the moment. But that's where we're at.
Too many changes.
Okay, thank you.
So you're seeing that Whittington and UCLH wants to merge as well?
Yes.
I only heard about North and Royal Free, but I hadn't heard about Whittington and UCLH.
Yeah, it's all happening. So JOS is rather full this year of big hospital central mergers. So yeah.
What's the criteria with the new government going on with it?
I don't know what the criteria is, or whether the new government will go along with this. I can't speak up. All I can say to you at the moment is that we've been very clear about we want very substantive reports around what's happening and the finances and the estates and the impact on residents from the councillor's perspective, obviously. Those are the sort of challenges we put towards our health colleagues, and then they come and present papers and we scrutinise.
My memory is we had really good discussions back in a few years ago about the issues of if you divide up services across sites and what that means, because travel to the Royal Free, as everyone knows here, especially if you don't have hard enough to pick car, but not near sort of impossible if you're unwell and you don't have a car.
Yeah.
And real concerns about that. I remember that being a hot topic.
So that's
I bet
that's
that will
on
range.
that has not that's on the agenda. So that's one of the bullet points that I put forward beyond. Conversation.
With the
But the St Anne's and the St Pancras, so the two different mental health trusts forming one, you know, joining, well, yeah, that's a discussion to be had as well. So believe me, they're all on the justice agenda and we're really on looking at those. But yes.
Okay, this is on a different subject, but one that I know that you've worked a lot on over the years, Lucy, and related to women and girls. Plan International that monitor and have surveys about the position of women and girls throughout the world, done a recent survey and said that their findings are that the UK is one of the most unsafe place to be a girl in the world at the moment. There are issues in relation to feeling safe at school, feeling safe in spaces, but also feeling unprepared for life because of education as well. Obviously, there's anxiety and mental health issues. I think all young people are common, and it's a lot of us do as well. The government have been talking about youth hubs. There hasn't been much in, but how do you feel they would work? You feel there should be, because boys and girls, teenagers of both sexes into their 20s, have very different issues, and girls wouldn't necessarily, and young women wouldn't necessarily feel safe in a youth hub that had boys. Do you think we should have at least 2 of these youth hubs? And how do you think they would work? And maybe outline some of the work I know you've been doing in relation to women, girls, and women.
Sure. On youth hubs, so we have 2 in the borough. We have Wood Green, Rising Green, and we have a youth hub in Bruce Grove. Do I think we should have sort of single sex environments? I think my answer would be I would ask young people about that. I wouldn't answer for them. But I also would say that going where young people already are is important. So you're right, we have quite a lot of work in schools, some of which we fund. I'm pretty confident most secondary schools in the borough have some kind of a programme, either one that we are involved with, some of the stuff that Solace Women's Aid delivers on our behalf, and other organisations, but some of them have gone for other organisations that looks at healthy relationships and looks at women's safety and etc. And some of them have workshops that are single sex, some of them have mixed groups. Now, when I was at a group with the young women last year, it was quite interesting because they were very vocal, but very appreciative of having a single sex space, but also had talked about being in mixed spaces and being able to say and tell boys, okay, well, this is how, when you do Y, this is what it makes X feel, etc. So that's one side of it. We're also beginning to do some work. We have some work with some schools on perpetrators and boys as we focus. You're right, there needs to be that kind of focus, not particular, but that's only just the beginning. So I think that's a good foundation on which to start. We've begun to do some work in parks because you've told us that some outside spaces and parks are safe. There's more to do there, but some of it's about lighting, some of it's about owning the space and making sure that that we provide an environment that encourages people to be active. And when we talk a little bit about being active, walking, interacting, or cycling, or using a wheelchair or another kind of wheel to mechanism for transport. Some of it's also about the fact that in spaces, when we design spaces well, people use them, people interact, can feel safer. So there's something about that connection between placemaking and safety. Just reading down some of the points that you made from the Planning International Survey. Mental health and anxiety, you're right, the new government has made a commitment to looking at mental health in schools and having increased workers in schools that provide undoubtedly that. I think personally, I'd say what I've seen in some Haringey schools is some really good practice. Working with our young people, doing art, doing therapeutic interventions. It's educational and therapeutic. And I know during the pandemic, some schools did that well, not all. But I'd welcome that commitment and that government bringing that to fruition quickly. What some of us did, including myself, is met with Luciana Berger, who'd been tasked with looking at what are some things we could do early on before the election, and we met with her and talked about one of the things that came up strongly was young people and mental health and having a more resource within schools to support young people. So it's about culture, isn't it, and about attitudes in society. So we've been trying out some campaigns, and actually having my inbox is really useful. Tried out a BMAT campaign during the Euros, and part of that was about learning that some of it. We had some really good learning feedback on people's attitudes and approaches. Interestingly, but maybe not surprisingly, people fed back that the posters in the backs of toilets doors, which we know they're used in this building, we know can be successful, had quite good people click through, and more so than in some of the maybe the beer backs themselves, etc. So some learning from that for more campaigning. We know the Mayor of London responded to some of us local authorities feeding back on women and girls' safety by doing some of his own campaigns. I'd like to see more of that and more of a dialogue with men and more of a dialogue about male and life there. So those are the kind of things I think we'll be talking about going forward at those different levels of government. Does that answer?
Maybe just a follow up, just to say that what everything you say, it's important that we all think about how we can include younger people into our decision making processes. And the other thing is, yeah, exactly, you're exactly right. It's boys and men of all ages be aware of what their behaviour does, and obviously make sure you keep us male counsellors informed about what's happening and what we can do actually to make a real positive difference.
Noted. And also, we have I think when I talk about it, a youth champion in the borough, male council, and I think I'll be really useful having a bit of a dialogue, but I'm sure he'll be up for that. But also, I know that part of his work will be around engaging people, and I know lots of young people in the borough are looking forward to that. But I'm sure that will be helpful in us learning and thinking about how we.
Thank you. I've got a question on Harrogate Opportunity Project, HOPS, which I didn't know was the acronym, and I actually didn't know this is what it was called. I know, so it's the people with learning disabilities and complex needs, and it's World Round Way and we've got Centre 404 to run this. Apparently, there's just been a review that's come out, which I've not seen. And apparently the findings are going to the co-commissioning group. But I think something that was just highlighted to myself, and as I said, I haven't seen the review at all, was that one of the main concerns raised by I think some people who've seen the review was that before that happened, they were very concerned that this centre wasn't being utilised very well. They said there were very limited numbers of people attending. It's a great building. I mean, you and I both went to when it all opened, didn't we? To have a look at the actual centre, and it all looked amazing. But they were saying that there wasn't many people who were sort of utilising this service. And actually, I think there's a challenge around whether the offer could be more innovative and exciting for the for the people that are using this. So as I said, I haven't seen that, and I know it's going to a different group. It's obviously not coming here. It's going to a different design group, co-commissioning group, to be looked at. But I think I just wanted to bring that to your attention. I don't know how closely you are involved in that group and what your knowledge is of that. But I just wondered if you could give us any reassurance about if there's a plan to sort of look into this a bit further and where this is going, the service run by Centre for Oakford.
So when I can, I do attend the commission. I think the really important thing is that we listen to users and we hear what they say and we adapt and develop services that meet their needs. And if something doesn't work, we need to adapt that accordingly. So I can give you that reassurance and I can get you a more detailed answer, but probably not before we kind of publish the report. Do you want to come in with something a bit more?
If I may. So the review came out of the JPB. So when I went with Andrea to the JPB, there's those that raised issues around potential low numbers.
Yeah.
So myself and Andrea went that day. So it is low numbers, but it's also our most complex vulnerable adults that we manage. Some of those have very intensive care packages, and there is some things that happen on a weekend there as well. So it's the Joint Commissioning Board, Co-Production Board. They agreed to do some sort of review just to look at what options were. I haven't had line of sight for review, but I do know it originally came from the JPB and the visit. So it's a really supportive, productive line of thought for it to happen. So I'll chase up the review and the outcomes of that.
When we've had the board, etc., we'll do a written answer to saying where we've got to and what the findings are.
No,
because no numbers can be a bad thing because it means no one's going, or not necessarily though, because if we have to meet a need and that a place meets a need, might be a good thing.
No, I just remember the excitement when it all opened, and as we went to visit, and it was, and I just thought, oh, I really hope this is going and it's, it's doing well, and if not, then there is this opportunity to relook at what the offer was. So, okay, thank you, that's reassuring. And then I had a quick question on finances, because obviously we all know that finances are difficult at the moment. So I think there was two things really. One is about the confidence that you feel in this next round. I mean, obviously there's going to be started the next round of savings. There's going to be that next round of looking at where we can, assuming, reduce money within budgets. There was a big overspend this year. Was last year, it's just been, and 1/3 of the savings weren't delivered in the financials. So 1/3 of the money wasn't deliverable. So what's your thoughts this time on how that could be improved, and there could be we get that surety that there's not I think one of the comments were there were stretch targets which weren't really, there was the confidence whether deliverable or not. So I think it's around the confidence around the next set of savings. Is there going to be anything done differently this time that you think, okay, that will really help in that respect?
So I might come in and make some observations and then ask people inside of me to talk technical. It's difficult, isn't it? Because it's a really challenging environment we're operating in. Yeah, we had a really huge overspend, but it's not unusual. And when you look at many of the other local authorities in London and beyond, they're seeing those kinds of pressures. Do we need to be good at delivering savings? Absolutely. Some of the things that we've done differently this year is we have a huge the whole structure around the project management that's been put in place. There's a board that meets regularly to look at where we are on those targets. You already heard today from Vicky that we've already made some inroads on CHC That's really positive. That means that's in the bag. Undoubtedly, some of those targets will be harder. And the other challenge is at the same time as all that's happening, the environment around us is still changing. And so I'm as confident as I can be that we've put the right things in place, and we've put in, we've got Tom Alexander driving forward and those projects. We're recruiting into roles to help us deliver them. But they are changing and moving seas, and you know as well that we've done really confident. We've done some work on looking at what our costs look like, because there were questions about that raised. I think that might come up even in scrutiny, but we're very confident that our unit costs are more than others, but our demand is great. Hence, a really important conversation about early intervention and prevention. But the reality is, whatever we do now, we might see some benefit now, but it's about the future too. So we're living with some historic burdens too. So I'm as confident as we can be that we've put in place the right structures and the right monitoring. But you cannot say that there might not be challenges. Of course not. I'd be lying if I didn't say that the environment we're operating in is also very subject to all the little got a Shakespearean quote in my head, and all the unnatural shocks that take place, and we're vulnerable to those things. But I think the team is very solid, and there's a real focus. And I meet every month finance with the team and with the finance team. And I also think we have a new director of finance, and this is no disrespect to John, who was brilliant, and Sir Karen gave well many years, but Taryn has new ideas and new approaches too. So as we go into the new budget round, which I felt like you're alluding to too, we'll be looking at that. But right now, at the moment, we're not at that stage. We're at where are we going to go next, and understanding what the environment looks like for us.
Yeah, we from adult social care, we overachieved our budget efficiencies last year, not under. So I'm not sure.
Savings.
The savings.
So in the financial outturn report, it's got that there was there was 2/3. I've got my, hang on, I might be able to get you the page number, but I haven't got the report in front of me, obviously. So maybe that's just something that was in the report.
Sure, that's about
6.6 of the report.
We had 4.5 and we achieved 5.1, so it must be a wider thing.
It's probably adults, health and communities, which has housing demand.
It might have been. That's possible.
Just found it, Chair. The other thing is this year we have got significant savings as well, and whilst it's challenging, there is a really robust team around that. And we have, even 2 or 3 weeks ago, reprofiled to move, so it's quite fluid. If we feel that we're not going to be successful in one area, we will reprofile. We're going to be doing that every 6 weeks. There is a weekly budget board as well internally in adult social care. Lots of things happening, and hoping for the absolute success, and we, got the right people around it.
It's 6.6. It says, following a review of assumed savings as part of assessing the 24-25 budget, 2.015 million of the non-achievable savings have since been no longer achievable, largely within the adult social care, and have had to be removed from the budget. Some of these were stretch targets achievable. So it was just really
before.
Right. So just the year on that. 24-25.
If it's helpful, Chair, we might need to bring Tom or key members of the team to come at some point at the right moment to talk about where we are at.
Okay.
At the right moment. I don't know when that will be.
Budget. Thank you, Sarah.
Well, it was just to say that there was a gap on a commissioning line that was a wider one. It wasn't directly within the purview of adults. It was an adults, health and communities one, and that might account for the difference. Beverly, I think you know about that savings line.
Yeah, it certainly wasn't adult social care. It was a very stretched target that we tried to look at preventative activity, and Will and Sarah actually sort of sponsored that area. Yeah, but it wasn't ASE, and because it was very stretched. There was that exercise just to classify it, as you've just said, unachievable.
I was going to say, we know you might want rewriting of those papers. You might want to clarify on your.
No,
You get your blame.
it was a commissioning stretch target, but it wasn't, it was a wider AAC portfolio, not ASC.
Right. Okay. Thank you.
But
Actually, you'll have the outturn at the point. Yeah. That'll be a good time, I think, to talk about how we're doing. Yeah, and then Vicky can present how CHC achieved
The finances. We will do. We've got budget coming up. So Councillor Donovan wants to.
Yeah, I mean, it's based on things you've said, but will it also ease things that the fact we're likely to have a multi-year settlement with the government? Could be 3 years, be nice if longer. And that means that I think you said that the put money into something we won't see the return for a number of years. And I know you've mentioned before about the social return on investments, is that accounting? So that if we invested in an organisation now, community organisation and price organisation, they will produce social value returns basically to the borough because of helping people with their finances that will actually in the long term help us. But obviously if you're just working on a year by year budget in the past, those things disappear.
Yeah, so agree. 25-26 won't have more this year. Is after the savings after the spending review that we'll have the commitments being for multi-year. Yeah, so when we get there, absolutely, I will look forward to seeing the back of these year by year. It's impossible because if you think about it, by the time you've done, get the money in, you know you've got the money in, and then 3 months just preparing, recruiting, etc. You've lost some of the year. And then what happens at the end of it? It makes no sense. At the end of functioning for 8 months, you then stop, because so I think you're right, multi-year will help. But not for 25-26 because it's up to the spending review.
Okay, thank you. Well, we have gone a bit over time, and apologies because obviously we were a little bit more engaged with wills, and we sort of took a little bit more longer on that. So I just want to see if there's one last question for Councillor Stairs, but then we'll close this item.
A big one, Councillor Desnes.
Yep.
Maybe is there an update on Canning Crescent and all? Are you
Yes.
provide us with an update?
Yeah. So I did another cabinet member signing, and the aim is opening January 2025. And don't rest assured, no one's looking forward to it more than me. It's just been complicated with suppliers, and I think the quicker we get it done, the better, and we can move forward, I think.
Okay, so thank you, Councillor Desnes, and to all the officers and all the people who gave their own evidence data scrutiny. Thank you, and to Sarah, thank you very much for coming on. Good night. So just quickly, the members before you resign. Thank you. We've got the work plan. So Dominic.
Yes, so just to draw everyone's attention to page 40, where we have the meeting before 25. Now we have a scrutiny cafe event planned in September, I think it's 20th of September, which will help to determine the items for this year and also for next year. But that's not going to happen in time for our September panel meeting. As you can see on page 40, we've actually brought forward the Haringey Safeguarding Adults Board annual report. We have that as a standing item that we have every year, and that's normally in November, but Dr. Ada Cooper can't make the November date, so we brought that forward to September. Now, we normally have the quality assurance and CQC overview at the same time. That's currently penciled in for November because that's when it normally is, but we could find out whether it's possible to bring that forward to September as well. Councillor Connor has an agenda planning meeting with Beverly and Vicky and Councillor Neves next week, so we could, that's possible. But that still isn't a full agenda for September, so we are looking for possibly one or possibly two items for that date. There are some sort of leftover items on page 41. 19th of September. So on the last page of the agenda pack, page 41, there are some older items that we've previously talked about possibly doing. So those are options for bringing to September meeting, but there could be other suggestions as well, of course.
You want to just mention before we go into that what we're doing with the panel work that we did the year project. So
Yeah, so we are behind schedule as you know on the discharge program. So we've got all of the evidence collected, and we had a first draft report. Now that we've got our July meetings out of the way, I think Councillor and I are going to meet to provide some of the recommendations, and then we'll put that out to everybody for consideration.
we have to get that done by mid-August.
Yeah, I think so. Yeah, I mean,
So that's 2 weeks. So
yeah, it's
no, I know it's just, but otherwise when it hits September, it's the new year. If we don't finish off this report, then it'll.
the information is all mainly there. It's just about getting the recommendations
So just be
straightened out.
aware that it'll coming into your inboxes around mid-August.
We want to give you a week or two to have a mull it over.
Yeah, okay, great. And just also quick, sorry, Councillor Mason, before you say anything, we've also got the Scrutiny Cafe coming up, but that we won't, the coordination of that, it is too short notice for the actually to have anything on that agenda from the Scrutiny Cafe in September. So that's why we need to sort of work out now what we want on the agenda. Because obviously officers need to put
I believe it's the 20th of September, but I would need to. So that's actually the day after our next panel meeting.
Yeah, the reason I say is this is a political thing. Labour Party conference is the following week, and a lot of us will be at. Yeah, not just.
You tend to keep those.
Conference is the week after.
Yeah, we tend to keep those dates free.
2nd to the 25th of September.
Right.
But this Scrutiny Cafe has been done with OSC chairs, which are mainly Labour, so they.
Yeah, so it will have to be the 20th.
I'm pretty sure it's the 20th. I don't think it's any later, and we do have an Excel sheet with all of the conferences blocked out so that we don't put meetings on those
That's been done.
dates.
Has agreed this, so.
Should have your conference in there as well.
We have the Lib Dem conference in there as well. Yeah.
It's all good. Councillor White thought this would be, anyway, so those are the dates that come through. But I think for what we need to do now is that there will potentially be a CQC report, the Haringey Safeguarding Adult reports, which are the two big items that go together, but we have then got space for a third item. So obviously I've got a planning meeting, agenda setting meeting with councillors and officers, but it's really helpful. Councillor Mason, put your hand up.
Yeah, I don't know how long it is since we've done a review of mental health services, but
Check. I'd have to go through the minutes, but we've had the mental health trust all along from time to time.
It's been regular report back scrutiny, but I will check.
in particular, we're just saying that relationship to that and these mergers as well.
I think it's going to be a bit early to do the mergers because they're not giving us the information yet, Joyce. So I think without that to hang it on, I think it's going to be quite difficult for us. Because we will ask questions, but no, we won't get the answers. Yeah.
Okay, if I can just say that my major concern around mental health services is transition from children to adult. And just a report on how well, whether there have been any changes, and if there have, whether they are satisfactory and how we know, because that is such a big area of concern.
We have done on transition. So I will Dominic will check back and find out when's the last time we did that. We've definitely done that.
Yeah, the transitions one was a few months ago, I think, but that was all transitions. That was all that was the range of things, not just mental health.
That was a joint one.
Yeah, so that was we can take it as a panel, but I will look back and see.
I'll dig out the minutes and the links, and I'll send them round of the relevant meetings that we've had.
Yeah.
Yeah, it was a 1 page 41, the first one, relation. I think we raised this before, whether we're going to discuss dementia, some of the work that's been done by the dementia coordinator and all of the groups that are involved, and obviously some of the stuff that Sheila's been talking about earlier as well. And it would be good to get to have a full review of the work that's been done and what further work can be done in relation to supporting people who are living with dementia.
I think from memory though, the suggestions on that first bullet point came from a meeting at some point last year where we had some discussion about it. So yeah, but I think the specific, I've obviously recorded those very specific items there, things that we wanted to track. So yeah.
Opening a dementia cafe, top sports centre.
Good. Great.
What's the list? That's
Okay.
good.
So we've got dementia and mental health, especially within the transitioning.
Right, so can I just say, first of all, does this mean that you've got a space in where the where CQC and safeguarding work for other things?
So
I'm just asking, is there now a space?
So yeah,
So, what I'd like to put forward is probably not going to be very popular but it needs to be done soon because it's likely to happen, and that's the preparedness for a future pandemic. I think it's so easy to put that one off and off and off, and then it'll happen. We won't have talked about it, and there are already a couple of strains that are looking quite worrying.
Well, I think that's helpful. So there's been some new focus, isn't there, recently, nationally on this. So I'm sure Will, if you were sitting here.
So I'm putting my hand up for that one.
Yeah, you're putting your hand up for that one. So Dominic, we're taking notes of all the ones that are being suggested. Helena, is that the one for September, or was this one for June?
Well, I just think that there are some really ones talked about, but let's just think that those important ones can be put in September and November.
Okay.
Is what I'm saying.
Right. Thank you.
I don't mind that being in November, but please don't leave it off the agenda. Like, it's so important.
That's a really good suggestion. Thank you.
So what to make Helena is that, obviously the commission has passed its interim views, and some of those were actually on preparedness. So whether actually as part of that scrutiny, we could provide someone to talk about essentially what was the outcome of that commission, what are the things that we can do. I suggest maybe we should wait a few months for some of that,
Just don't wait.
to maybe not in September, but the one.
I'm saying November. I don't mind it being in November, but just
I think
don't
there'll be more
leave it off.
information and more expertise to come.
Just on the issue of prevention, early intervention, the issue about climate change and its impact on our population and the health of our population. Is there some work being done on that in the council? Or just because we know that we're going to have far warmer summers like this week and far colder winters. So
no winter fuel allowance.
Yes.
Harrogate deal? Does Harrogate deal cover any of this?
The impact on health is quite a serious one.
Sort of cover, I don't know, does it cover anything?
Is that a question maybe to ask Mike?
Yeah, I was going to say, if you have a conversation with Mike,